Hello everyone, I hope my audio video is clear. Hello Purnima, please let me know if my audio video is clear. Hello Ayash, good evening. Dr. Fit, hello. Abhinandan, Vivek, alright. So let's start with the hemat, right? And today what we are going to do is, just give me a minute. ये अभी वाला चल रहा है? Okay, fine. So let's start. So hemat में सबसे मुश्किल क्या लगता है? What do you think is the most difficult part in the hemat? I'm talking in terms of WBC, RBC and platelets. What is the most difficult part over here? What do you think? Hello Ramesh, Aryan, Deepak. Hi guys. So tell me, what is the most difficult part over here? WBCs, RBCs, platelets. Namaste. I hope it's working. I'm asking some question. WBC. Yes. Right. Most of you are saying lymphoma leukemias, WBCs, right? So that is something we fear of, because definitely, yes, it is most important part, and it is having many things which are factual, and they are going to give you the peripheral smears, and we fear of that. Right. So most of you are saying the WBCs, and one answer I got from that is platelets. Okay, platelets are pretty easy if you understand the concept. But in the WBCs, you have to have the concept. With that, there are many facts. What are the genes, what are the CD markers and how they work, right? And the smear, how to identify the smear, various different types of smears. Right, I hope you got the PDF, right? And what we are going to do is, we are going to deal with the WBC part today itself, right? So that the easier part remains for the tomorrow, right? So are you guys ready? Full hematology is confusion. So let's sort those confusions out, right? So yes, डर के आगे जीत है, randoms, right? So what we are going to do, one by one, we are just cutting down the fears. Whatever you are going to do over here, you should be doing it with your 100% concentration, attention, right? So whenever you are attending any class, not my class only, but whenever you are attending any class for that matter, attend it till the end, so that you won't miss anything, and whatever time you are investing, make sure that it is going to be worthwhile. Right, good evening. So have that belief that yes, it is going to be easier as you revise it, as you understand it, right? And be like the stem cell, differentiate yourself from the others, right? There are many people in this world, but we want to show that yes, we can do it, right? So with this message, let's start. I hope, yes, many of you joined over here. So let's start with the class, right? So first of all, I'm going to give you the introduction. In the introduction, what are the cells that are formed from the stem cells? So can you tell me what are the two lineages that are present? What are the two lineages that are present? Usually whatever your Telegram group is there, I have sent it there, right? Yes, Telegram group mein is there. Thanks, Purnima. So what are the two lineages? What are the two lineages? Lymphoid and myeloid. See, first of all, first thing first, I do not want these type of question ki PDF kahan milega, kab tak hogi class, break kab milega, hai na? So these are something very, it's very distracting messages which we get, hai na? पढ़ने आए हो तो पढ़ाई करो, right? So what I'm talking over here is about WBC, so concentrate on that thing, right? बाकी सब कर लेंगे sort, right? If you're not getting the PDF, just note down the main points and then you can write it on your own notebook, okay? Chalo. So have that faith that everything will be good, and let's start with the class. Concentrate on the class. That is first thing. We know that is a stem cell. Stem cell is also known as hematopoietic. Hematology पढ़ रहे हैं तो hematopoietic. Now there is one term which is known as poetic. What do you mean by poetic? I am not talking about poem वाला poetic. Okay, this is hematopoietic. Poetic का मतलब होता है production. So what we are producing over here, we are producing the hematological cells. So that's why it is also known as hematopoietic. The cell which is producing the blood cells. So that's why it is known as hematopoietic stem cell. So please make a note of it. So that is known as hematopoietic stem cell, है ना? I'm good, guys. Just concentrate on that, right? Then we do have myeloid and lymphoid stem cell. Everybody knows this, right? Lymphoid, myeloid stem cell. Now focus on one thing over here, that there is going to be precursor cells. It's not like once the hematopoietic stem cells start to differentiate, it is going to form RBC, WBC and platelet, right? So what it is going to do, it is going to have some stages. If you know that stages, that is going to be very, very easy for us. Okay. So what are the stages? There are many stages we are going to learn step by step later on. Just for overview, I'm telling you that the RBC is formed by, yes please, can anybody tell me RBC is formed by and the platelets are formed by? What are the precursor cells of that, right? ये direct question आता है आपको. What are the precursors of the RBCs and platelets? Tell me that. Okay. And myeloblast, it is the precursor of the WBCs. Now, WBCs are of various type. As we are going to move ahead, we'll see that. But mainly you have to understand they are of two types, granulocyte and agranulocyte, जिसमें granules दिखते हैं. The cells in which you can see the granules, they are known as granulocyte. The granules are present in both, but can we see that under the microscope or not? Depending on that, we divide them under granulocyte and agranulocyte. Erythropoietin is the factor, colony stimulating is the factor, not the precursor. Precursor मतलब वो भी cell होगा, है ना? Immature cell, like you are also about to be doctors, but not doctors, है ना? But you are human being, right? So that's how the erythroblast, there is no erythroblast. Please remember, erythroblast comes much earlier, right? Yes, erythroblast is there, but the precursor is just before the RBC, whatever cell is present. That is known as reticulocyte. Okay, so these are reticulocyte. Erythroblast, proerythroblast, they come in the lineage, but that is not the precursor. Precursor means just pehle, just before forming that cell, that is immature, or this is known as the precursor. Pre means just before what comes, right? After which these main cells are formed. So precursor for the platelets, what is it? There is a fun fact that the largest cell, yes, Yogi, you are right, the largest cell in the bone marrow forms the smaller, tiny plate-like cells, that is platelets. Okay, they are not even cells, they are the fragments of cells. So they do not contain any nucleus also, है ना? So बड़े को क्या बोलते हैं हम? What we call it as? The bigger things we call it as mega, right? Just like mega cell and all. So megakaryocyte. So please make a note of it. Megakaryocyte forms the platelets. Okay. So what is the fun fact over here? That the सबसे बड़ा cell forms सबसे smaller tiny plate-like cell, that is platelet. So megakaryocyte is going to form the platelet. Okay. Then comes the granulocyte. We are going to talk about them in the detail, but just remember neutrophil, eosinophil and basophil, these are the platelets which are already given on the slide. There is no lymphocyte. There are many types of lymphocyte. Just remember, lymphoblast is the precursor for lymphocyte. It is pretty easy. There is no something in between. Okay, lymphoid stem cells से direct lymphoblast बनेगा and then it is going to cause the production of the lymphocyte. Right. So that is there. Now let's move on to the WBCs. For some time we are going to keep aside the platelets and the RBCs. We'll learn that tomorrow, right? Now we are going to take out the most important part, the most important fear. We are going to take it out. Okay, so that is about the WBCs. So what were the two lineages of WBC? Yes, please. Lymphoid and myeloid lineage. Can you tell me, with the lymphoid lineage, what will be formed? Lymphocyte. How difficult it is, है ना? Lymphoid से lymphocyte बन रहा है, right? So it is pretty easy, right? Myelocyte से WBCs. Which WBCs? Granulocyte, monocyte, and over there the lymphocyte. I cannot say it as granulocyte and agranulocyte. Understand, the lymphocytes are agranulocyte, but with that monocyte में भी हमें granules नहीं दिखाई देते. So in the monocyte also we cannot see the granules, right? So lymphocyte, yes, B lymphocyte, T lymphocyte, all of them, right? So first of all, agranulocyte, understand, agranulocyte are two cells, monocyte and lymphocyte. अब बताओ मुझे granules किस किस में दिखाई देते हैं? In which cells we can see the granules? अभी तीनों हमने पढ़े थे. What are the cells in which we can see the granules? Yes, please. Right. So what are the three cells? Please make a note of it. I don't know what is written in your PDF. There are some empty pages are there, right? So yes, neutrophil, basophil, eosinophil. Very good, random. So these are the main. तो याद कैसे रखे? In which the fill is coming. That is filled with the granule. So please remember, eosinophil, basophil and the neutrophil, they are filled with the granule. So please remember, rather than writing filled, I am writing filled. Okay, so they are filled with granules. So please remember, जिसमें भी fill आया, so they are granulocyte. So they are filled with the granules, and that's why we call them as granulocyte. Okay, रट्टा मारने की कोई जरूरत नहीं है, ये पेज तो देखने भी नहीं है रिवीजन के टाइम पे. Okay, so this is how you are going to identify if the question comes, right? अब आते हैं hematopoietic stem cell. इसी से सारे सेल बन रहे हैं. All the type of cells, they are formed from the, right? NB, right? NB is fill, है ना? F से कुछ और भी आता है, but we are not going to say them that, right? So that is there. NB is definitely a nice mnemonic, right? NB is fill of bullshit, है ना? Filled of bullshit, not with the granules. Anyways, चलो. So hematopoietic stem cell, they are CD117, which is also known as c-KIT, and CD34. ये तीन चार बारी out loud, just speak it wherever you are, and just yes, fills are easy, right? So what we can do is just say out loud or say it in your mind, or if you have rough book on your side, just write it down, because again that is going to create the hand memory. Why we ask you to make notes? Because definitely there is something known as hand memory. Okay, physio में आपने पढ़ा होगा, I am sure. So what is hand memory? Whenever you write, your brain interprets that something going on, I should pay attention. Okay, so that creates or generate a short-term memory. If you revise that many times, you are just converting into the long-term memory. So I'll just suggest, if you have a rough book, please make a note of it. If not, just say it out loud if possible. Okay, if you are sitting in the library, don't say that, right? So CD117 and CD34. This is going to be the hematopoietic stem cell, right? So stem is 34. Now coming to the lymphoid and myeloid, two lineages abhi padha humne, right? Lymphoid, we are going to divide that into two, and myeloid. For now, just remember, M अगर आप उसको tilt कर दोगे, if you tilt the M, that looks like 3, right? So if I tilt this M like this, so suppose I wrote M like this and I tilt it, it looks like 3. So please make a note of it that myeloid कभी भी आएगा. So overall myeloid lineage, if I want to check whether it is lymphoid or myeloid, I'm going to, if I got CD33, I'm sure that it cannot be the lymphoid, it is myeloid. Okay, so double 3 करना है हमें. Myeloid में just 3 and 3, that is myeloid. Okay, easy. 117 is just yes, right? So let's move on to the next thing. T cell and B cell. Can you tell me what are the markers for T cell and B cell? Yes, please. T cell के markers बताओ, B cell के markers बताओ. At least you should tell me what is the pan T cell marker and pan B cell marker, even if you do not know all the markers. So please tell me what are the pan T markers and what are the pan B markers. Okay. What are the pan T markers and B markers? Right. Mnemonic में उनका जिक्र कर रहे हैं because they made our life very hard, right? So that's why we have to remember them. T cell tiny numbers, right? So number भी बता दो यार. What are the numbers? B cell big numbers, very good. What are the numbers? Yes, you are absolutely right. So pan T3, pan T is T3 याद रखना and B is B19. Okay, so B is 19 and the tiny numbers are 3, right? So what are the tiny numbers, by the way? याद रखना 2 to 8. All are the markers except there will be options except which of the following is not the T cell marker. Your options are, let's say 3, 4, 5, 6. So which one of it is not the T cell marker? Tell me your options. A, B, C, D, right? So let's say 3, 4, 5, 6. So except will be there, right? So which of the following is not the T cell marker? Right, you guys are absolutely right. So that is going to be except 6. So except 6, all of them are tiny numbers, as someone said correctly. Tiny numbers are going to be the T cell markers and the big numbers are going to be B cell markers, right? B cell markers are from 19 to 24, all of them. 19, 20, 21, 22, 23, 24. Okay, all of them are the B cell markers. But remember, T cell marker and B cell marker, right? Priyanka, Osama, Yahia, Yogi, you guys are rocking, right? Arefa, oh, absolutely right. So these are the pan B, pan T. At least you have to remember. If you tell me, ma'am, tell us that from this slide what to remember. So please remember pan T and pan B. Next come pan B is 19, but rather than giving CD19, this is 19 is CD19. Rather than giving the CD19, they can also give you some antigen, which is common ALL antigen, that is Kala antigen. Okay, and that is the Kala antigen is the CD10, right? So Kala antigen is CD10. Please remember the lymphoid leukemia mein we are going to talk about it, but please remember, yes, it is lymphoid, but it contains number 10. So CD10 can be positive in the ALL. So yes, it is going to be lymphocyte, but CD10 will be positive, then definitely it is going to be the Kala antigen. And one more is there, that is nothing but the PAX5. That is nothing but PAX5. So please make a note of it. Kala antigen and PAX5 are also going to come with the CD19 to 24. Right? Right. Let's move on. Right? What is the normal count? Can you tell me what is the normal count of WBC? White blood cell ka normal count. Tell me what is the normal count. Why can't you focus on the studies rather than comments and names and everything, है ना? We do have limited memory. What do you want to fill in? कि break कब मिलेगा, PDF कब मिलेगा, class खत्म कब होगी, शुरू तो करने दो, है ना? What is the name? कौन कौन आए class में? Why guys? चलो, answer दो. Arkdeep, Andrew. Yes, answer please. Right, you guys are rocking. Yes, so 4,000 to 11,000. Everybody is googling, I think, है ना? इतना time लग रहा है. So 4,000 to 11,000 per microliter or per cubic mm, right? So per cubic mm, that is milliliter, or microliter is going to be WBC count. RBC का कितना होता है? What is the count of RBC बच्चों? what is the count of RBC? RBCs are in millions, okay? This is in thousand and RBCs are in millions depending on male or female, but generally we say that 4 to 6 millions. 4 to 6 millions per microliter is going to be the RBC. Now, one more thing I want you to remember, that if you see the ratio over here, WBCs are in thousands, RBCs are in millions. So definitely there is going to be a ratio which we say usually, that is 1:700. That means if you have 1 WBC, you are going to get 700 RBCs. So that is the ratio. This is very, very high. If you make a peripheral smear, definitely you will be getting 1 or 2 RBCs, but 1 or 2 WBCs, but many, many RBCs in the background. All right. So that is the ratio. Why I am telling you? Because once we are going to move on, you'll see what happens in the leukemia and the other tumors of the WBCs. Right. Chal. Let's move on. So neutrophil. First of all, there is a mnemonic that is given, already I have given you. There is a mnemonic that is known as never let monkey eat banana. Now what is that? That is the count from highest count to lower, right? That's how we are going to go. First of all, what are the maximum number of WBCs are present? They are nothing but the neutrophil. Never let, L for let and L for lymphocytes. Then comes the lymphocyte, right? Then comes never let monkey, monkey, M for monocyte. Monkey eat banana. Eat banana is eosinophil, and then comes your never let the monkey eat banana, that is the basophils, right? So first of all, why the neutrophils are important? When the neutrophil will increase, neutrophils are usually 40 to 70%. You can make a note of it, that around 60%, right? If you have to choose one, go for 60%. Pyogenic infection mein then comes steroid and lithium. When we give lithium, bacho, we give the lithium is usually toxic, but in the lesser amount we can give for the treatment of what disease? Yes, we are going to cover many subjects. So what is the lithium used for? Then comes the lead. Lead was the lymphocyte. Lymphocyte कितने होते हैं? 20 to 40% lymphocytes are there. Why the lymphocytes are important? Where the lymphocytes are going to be useful, or something happens in our body or patient's body, and then the lymphocyte increase rather than neutrophil. Understand, who is the primary defense mechanism? That is neutrophil. Yes, bipolar में या mania में. Yes, absolutely right. Bipolar में as well as in the mania we can give the lithium. Very good, guys, very good. So in that you can find out that yes, the neutrophils are rising, but we know no need to worry. Why? Because we know that is treatment associated and not because of any infection. What do you mean by pyo? Pyo means pus. So whatever infections which are generating pus, right? So you must have seen various pyogenic infections. They are specially bacterial. So if बड़ी सी history दी हुई है and some bacteria is mentioned over there, you know that the neutrophilia is going to take place, right? So neutrophils are going to increase in the pyogenic infection. Good. Lymphocyte किस में increase होते हैं बच्चों? Where the lymphocytes are going to increase? Tell me. There are two important things. Every day you are going to see one kind of patient in which lymphocytosis is going to take place, and we are living in India. So there is one most common disease in which the India is the capital. In that also the lymphocytes are going to increase. So what are those two diseases? Tell me quickly. Yes. Viral infection mein the lymphocytes are going to increase. Please remember, their neutrophil won't increase, right? Usually you have that cold cough, right? In that, if the clear type or white color sputum is written, definitely it is viral infection. If yellow colored sputum is there, then it is bacterial infection, right? Usually we do have viral infections. They are more common, and you guys are absolutely wonderful. That is TB. TB is most common. जो भी information है related to TB, you have to know it. Why? Because we are leading the world in the TB. So definitely one question will be, I'm not sure of what topic, it may be of pathology, medicine, micro, anything, PSM, right? So the Indian government, they want you to know about the TB. So they are going to definitely give 1, 2 or even 3 questions on the TB, right? So please remember, in the TB, though it is the bacterial infection, but it is a specialized bacteria, right? जो इंडियंस को अफेक्ट करे वो भी बैक्टीरिया होता है, राइट? सो इट इज गोइंग टू अफेक्ट द lymphocyte. Even if instead of being the bacteria, the lymphocytosis is seen, this is a special case. So please remember. Next comes the monocyte. Can you tell me where the monocytes are going to increase? Please concentrate on the notes and the class, right? Again, I'm telling that, है ना? Focus on the main goal. So monocyte are 2 to 10%, and in the chronic infection, understand, if there is neutrophil and monocyte, if you see their size distribution, the neutrophils are smaller as compared to the monocyte, right? Monocyte, as they go in the tissues, what they are going to form? Macrophages. Macro means big, right? Macrophages. Phages means the one which eats the thing, right? So they are going to be, monocytes are going to have that indentation nucleus, and neutrophils are going to have tiny different nucleoli and their lobes, right? So please understand, if smaller infection for smaller time it is there, definitely already primary defense mechanism is there. So neutrophils are going to go and neutrophils are going to rise. But if from chronic time, long, prolonged infection is there, now it cannot be handled by the neutrophil. For the help, the monocyte comes, and the monocytosis is going to take place in the chronic infection, right? So please remember, and M for M, please remember, in the malaria also the monocytosis can be seen. Then comes the eosinophil and basophil. You cannot forget the eosinophil, where you can see the eosinophilia. 5 to 6 lobes are there, 7 never comes, okay? 6 lobes are there. Mad vision, only 6 lobes are there. It never happens that 7 lobes come. 7 lobe है तो वो hyper segmented हो गया, okay? Usually, normally in physiological scenarios, yes, till 5 to 6 lobes are there, right? So can you tell me eosinophil में कौन से granule होते हैं? Just now you guys told me NBE. E was eosinophil. Eosinophil will have acidic type of granules, and yes, E, that is allergy. E is eosinophil, and it is going to increase in the allergy. Why it is going to increase in the allergy? Is it helpful, or they're causing limit those symptoms? So are they helpful, or they are causing those symptoms? Tell me. Yes, I know you know that in the allergy that is going to contain, but yes, in the very old exam, that is around 2017, this question came that eosinophil granules contain which of the following? So please remember, histaminase. Actually, eosinophils trying to limit the symptoms of the allergy. क्या होते हैं symptoms? Various symptoms are there depending on what type of allergy you are having, and one major thing which can be seen, that is vasodilation, that caused because of the histamine. So we do not want the histamine to raise beyond the limit. Otherwise, what will happen? Everywhere the vasodilation will occur. And if everywhere vasodilation will occur, what is going to happen? The peripheral blood cannot come towards the heart. That means venous return is going to decrease. What type of shock it is? What type of shock it is? Yes. Excessive harmful, definitely yes, but they are trying to limit it. It is actually a protective phenomena. They are protecting us. Yes, collapse. But what type of, if the vasodilation history is given and they have asked you the type of shock, please remember it is going to be distributive shock, है ना? So histamine से क्या होगा? If the eosinophils are not there, histamine causes distributive shock. Yes, anaphylactic shock or distributive shock, right? So everywhere the blood is distributed, now there is no more blood to go towards the CNS, right? So brain will be not working, है ना, वैसे भी हमारा काम कम करता है, but at that time the brain won't work at all, even the normal things won't be happening and the patient will collapse. Okay, and it is also increase in the Hodgkin's lymphoma. We are going to see there is something known as eosinophilia is going to be seen in the Hodgkin's lymphoma. So please make a note of it that eosinophilia is going to happen, and eosinophil contains histaminase which will try to cut down that vasodilation and protect us from the anaphylactic or distributive shock. And definitely in the Hodgkin lymphoma also we can see the, तो हिस्टामिन रिलीज कौन करता है बच्चों? In the Hodgkin lymphoma we can see the eosinophilia, right? Right. आजकल ज्यादा नहीं काम कर, जितना काम करता है पढ़ाई में लगाओ. Okay, so allergy is going to be there. Who causes the allergy? Who contains the histamine? That is going to be your B cell. So who is the culprit? The bad boys are the culprit, है ना? So who are the bad boys? The basophils. Actually they are the culprit, but the eosinophils are more in number. So we think that eosinophils are causing vasodilation. No, they're actually protective to us, right? The bad boys are the reason, and they cause CML, that is chronic myeloid leukemia also, right? So here is our monkey. So please remember, never let the monkey eat banana, right? So क्या याद रखना है? 60, 30, फिर 6, 3 and 1. What is it? 60% are neutrophils, 30% are lymphocytes, 6% are the monocyte, eosinophil are 3%. So 60, 30, 6, 3, 1. Okay, easy. No need to even recall it again and again, right? Let's move on to the maturation of myeloid and lymphoid cell. We already discussed that. A simple mnemonic I will give. Myeloid का थोड़ा सा difficult है, that we'll see first, and then we are going to move on to the lymphoid one. Okay, so myeloid have many stages. See over here, it's pretty difficult. First of all, the blast cell is going to be there. As soon as the HSC, that is hematopoietic stem cell, is going to make the cells, what is going to happen? Myeloblast will occur. Myeloblast will form what thing? It is going to form promyelocyte, which will form myelocyte. Myelocyte will form metamyelocyte. These three things you have to remember it. Why? Because again, when we are going to read the Fab classification, then this is going to be very important. Okay, promyelocyte, myelocyte, metamyelocyte, then comes the nuclear band and the neutrophil. This is especially for the neutrophil because again, कोई भी myeloid lineage is going to increase, definitely the neutrophil numbers are going to be much higher as compared to other two types of cell. So that's why we talk in terms of neutrophil basically, right? And lymphocyte is pretty easy. Blast cell will form pro-lymphocyte and then it is going to form lymphocyte. That's all. Only two things. What are the two things? Blast cell is always going to come first, right? As soon as the stem cells are going to divide, they are going to form blast. Okay, that blast will generate the further lymphocytes. So either they are going to be lymphocyte, then the blast cell will form pro-lymphocyte and then it will be converted into the lymphocyte directly. But in the case of the neutrophil, myeloid में क्या होगा? Yes, the blast cell will be formed, but then forms the promyelocyte, then the myelocyte, metamyelocyte, right? Now this is not a monocyte and it is myelocyte. Why I am saying so? You'll understand later on. Okay, let's move on. So can you tell me when, in which condition we can call it as leukemia and when we call it as lymphoma? Okay, so let's start with the basic. Now we are going to move on from here towards the leukemia and lymphoma. आराम से जाएंगे, but yes, we are going to clear all the doubts. Okay, tell me what is the difference between leukemia when you say that this is leukemia and when do you say that this is lymphoma? Leukemia में excess is going to happen in both. How I am going to say that whether it is lymphoma or leukemia? See the word over here. See the word. You must have heard of natremia, kalemia, uremia and so on and so thing. What does this emia means? इसका मतलब क्या होता है? द एमिया लिटरली मीन्स ब्लड. Latin literature हम पढ़ते हैं, right? Usually all of the medical literature, out of that 70 to 80% of the literature came from the Latin. Okay, so this emia word came from the Latin. जहाँ पे भी emia blood आ रहा है, that means something happening in the blood. Okay, uremia, natremia, kalemia, calcemia. So everything is happening in the blood. So leukemia, leuk is white blood cell, emia means blood. If the white blood cell are increasing beyond a limit, that is mean by the leukemia, right? So leukemia क्या है? There is special type of cell. What are the special type of cell? Immature cell, we can call them as blast cells. Blast in the blood is known as, so please remember, blast in the blood is known as the leukemia. Emia means blood. Please remember that. Once you understood this, all will be sorted. Lymphoma. Can you see the word over here? That is lymph. What do you mean by lymphoma? Lymphoma affect the solid organs. Or you can say, first of all, we can start with the lympho-reticular organ. So please make a note of it. Lympho-reticular organs. What are the lympho-reticular organs? Can you name some? First is the liver, then the spleen, then comes the lymph node. Definitely yes. There are special type of lymph nodes which are present, which always hurt us whenever usually the general cold and cough like symptoms occur. What is it? Thank you, right? What is it that hurts us always whenever the cold comes or viral infection occurs? That is the tonsils. Tonsils are again what? They are the lymph nodes, right? And the pharyngeal lymph node, which is also known as Valdeir's ring. Okay, so there are special type of lymph node. Yes, tonsils, very good. So tonsils, and there are special type of lymph nodes which are known as Valdeir's ring. So in that, if some tumor is affecting Valdeir's ring, there was a question on this Valdeir's ring. So tomorrow I'm going to show you the questions because I couldn't make the questions today. Tomorrow we'll be solving the questions. Okay, so Valdeir's ring, if it is mentioned, that means they are hinting you towards the lymph node. That means they are hinting you towards the lymphoma. Okay, and that's why emia won't come over here because they are affecting the lymph nodes or mainly the lympho-reticular organs. Now understand, this is lymphoma, but lymphoma can get converted into leukemia. For example, the proliferation started in the lymph node or spleen or wherever, but they came into the blood. So definitely some of the cell, they break off from the tumor and they came into the blood and they started proliferating in the blood and affecting multiple places. Definitely once they come in the blood, this becomes the leukemia, because we know as soon as something tumorous come in the blood, we call it as leukemia. That is our first rule. So if the blast come, no matter whether it is the lymphoblast or leucoblast, so even if they come into the blood, that will be leukemia. So yes, lymphoma can get converted into leukemia, but can leukemia get converted into lymphoma? Yes, why not? So they are interchangeable. So don't get too much stressed upon it. They can interchangeable. From the blood, the metastatic cells, they can lodge into some organ like spleen or liver and they start proliferating there. So this is nothing but the metastasis. So they can affect any of the organ also. So leukemia can get converted into lymphoma. Lymphoma can interchangeably affect the leukemia, or that can cause leukemia. Now, the one most important thing in the lymphoma leukemia is the peripheral smear. Both can change. Yes, Sini, you are absolutely right. Both can be there. Right. So, all right. So, peripheral smear. So, how you are going to identify which cells are lymphocyte, which cells are neutrophils, which cells are. So, I am marking over here. Please let me know what are these cells. Let's say 1, 2, 3, 4, 5. So, I am marking over here cells. Please tell me what are the cell and how did you identify? So if I write, this is the first cell, okay, this is the third cell, this is the second type of cell or second cell and second number cell, or So how you're going to identify? First of all, I need to identify whether I can see the granules or cytoplasm looks very clear, neat and clean, right? So first of all, I'm going to divide it into granulocyte and agranulocyte. So in which cells I can see a major granules that I'm going to see, then I'm going to focus on the nucleus ka shape and size, and then I'm going to go towards the cytoplasm. So three things I have to note down. Right. Ardip, are you asking me or telling me? Question mark क्यों है? Right. So yes, most of you are correct. So please see over here that first of all, we are going to see the granules and nucleus. So two things we have to see. So if you are having multi-lobe nucleus, more than two lobes are there, you cannot think of anything else than the neutrophil. So second is our neutrophil. So it is going to be neutrophil, and in the neutrophil we are going to have teeny tiny granules. Okay, this is not very clear over here, but teeny tiny granules are going to be there. So if you have two or more lobes for the neutrophil, don't think of anything else, right? Now over here you can see that there are three lobes as shown, and three lobes means it is none other than the neutrophil. Then comes the two lobe wale. Who are the two lobes? First is your eosinophil. Now yes, the nucleus can be of headphone shaped, or we say it is a spectacle shape, possible, right? But how to say that there can be a neutrophil which is having the two lobes also? So how to identify? Yes, I want to confirm that whether it is eosinophil or neutrophil. I'm going to see the cytoplasm. In that I'm going to see pink color, reddish or pinkish granules. So if I see that, you can see the dono mein difference, the color difference over here. Even if you can compare that with the nucleus, nucleus is blue because it takes B16, okay, and your cytoplasmic granules are pink, or we say brick red color in the cytoplasm, that is cytoplasmic granule. So number 5 is the eosinophil. Clear? Now see over here, what is this cell? There is some nucleus, but I cannot appreciate the shape of the nucleus. Why? Because there are multiple coarse granules are there. Yes, you guys are right. So multiple coarse granules which are covering the nucleus, and if the nucleus is covered by the granule, then this cannot be any other than the basophil. So please remember, this is going to be the basophil and basophil only. If you can identify the cell, you can definitely say whether it is lymphoid or myeloid leukemia. So this is important slide. So please pay your focus over here, right? So this cell and this cell, two things are different. First of all, their size is bit different. What is the size of lymphocyte? It is twice that of the RBC. You can see that the RBC is a double size, approximately double size, 10 to 14 micrometers. That is the size of the lymphocyte. And what is the size of monocyte? Monocyte is bigger, right? And what is going to happen over here? See, when I'm going to say that this is the monocyte, first is the monocyte and the third one is the lymphocyte. See over here, both are going to be agranulocyte. That means there won't be any granules, or at least we cannot see that. ये क्या है? फिर छोटा छोटा जो दिख रहा है, that is going to be the precipitation of the stain. It is not the granules that we can see, right? In the exam, they won't be giving you such kind of slide, right? So what we can see in the monocyte, that yes, the nucleus is going to be slightly indented inward, right? It is not going to be round nucleus. Yes, round nucleus can be found in the blast, but not in the mature monocyte. Monocyte में, how to remember? Monocyte में बीच में एक indentation आता है, right? So please remember, the monocyte का nucleus is also going to be indented. Okay, lymphocyte ka, that is not going to be the case. In the lymphocyte, what is going to happen is, lymphocyte will be covering most of the cytoplasm. So if you take nuclear is to cytoplasmic ratio, this is going to be higher in lymphocyte. So अगर आपको doubt है, definitely you are going to have a doubt in the myeloblast and lymphoblast. So make sure that you see the nucleus to cytoplasmic ratio. Usually monocyte में the nucleus is going to be eccentric. That means the nucleus is going to go in one side. But in the lymphocyte, what is going to happen? The nucleus is central. That means from all the side, usually you're going to have a cytoplasm. But if you compare the cytoplasm is to nucleus ratio, definitely it is going to be less, right? Cytoplasm is to nucleus ratio less, nucleus to cytoplasmic ratio higher. Nucleus बड़ा होगा, so जहाँ पे भी nucleus लिखा हुआ है उसके according ratio will change. How to identify that? Even I'm not understanding if both the cells are not shown, only one cell is shown and I'm confused about it. So what my rule says that, say around 40 to 50%, if let's say 40%, more than 40% is there, what the nucleus is covering more than 40 to 50% of the cytoplasm, it is lymphocyte. It cannot be monocyte. Monocyte 50% से ज़्यादा take over नहीं करता है. So if you can see over here, definitely the 50% area is of cytoplasm and 50% around area is of, yes, your nucleus. So that is how you are going to identify the lymphocyte and monocyte. So let's move on to the next thing, that is blast का classification. पता कैसे करोगे? Before you should know that before going to the leukemias and lymphocytic leukemias, myelocyte or monocytic leukemias, you should know what is the difference between myeloblast and lymphoblast. There is one mnemonic which is famous. Everyone will tell you that M means myeloblast. Everything will be more in the myeloblast. Okay. So what are the things? First of all, nucleoli. Nucleus में जो छोटे छोटे indentations are there, they are known as nucleoli. Can you see over here? There are two nucleoli which are present. Usually 2 to 3 nucleoli are going to be present. अगर nucleoli दिखे, so that means it is the myeloblast. Yes, and Argdip said very good. Yes, that is also going to be there. This is the OR rod, right? So this is going to be the OR rod cells which are going to be there. Charger. So that are going to be there also. So nucleoli, first of all, it is going to be present in the myeloblast and they are absent in the lymphoblast. Okay, usually you cannot see anything like nucleoli. Vacuoles जैसा कुछ भी आपको नहीं दिखेगा in the lymphoblast, right? Then comes the cytoplasm. M for more, M for myeloblast. So cytoplasm किस में ज़्यादा होगा? Obviously, this is going to be much more in the myeloblast. I told you. ब्लास्ट है, अब ये मोनोसाइट नहीं है. माइलोब्लास्ट में obviously the nucleus is bit bigger, right? But you can see a proper rim over there, right? And in the lymphoblast, it is going to be less as compared to the myeloblast. Okay. Then comes the OR rod. Now, what are these OR rod? Actually, I told you that depending on whether we can see the granules or not, we divide them into granulocyte and agranulocyte. But the granules are there. What happens that as the maturation occurs, those granules become more invisible for us to see under the normal microscope, compound microscope. Under the electron microscope, we can see the granules, but normal compound microscope, we cannot see it, right? So if I see the immature cells, they are going to contain the visible granules and those granules come together. They precipitate and form a line like something or form a rod like something, right? So that rod is known as OR rod. Okay, so this is going to be most characteristic, fundamental. If you see OR rod, what I told you, M is more. So in the myeloblast, you are going to be seen. So they are again present in the myeloblast and they are absent or they will never present in the lymphoblast. Absent or never present in the lymphoblast. If OR rods are there, and definitely if they give, they are definitely in the FMG exam, they give easier examples. So they are going to, if they want you to know that this is the myeloblast, they are going to give you the OR rod ka diagram. So please remember, nucleoli, OR rod, cytoplasm, more in the myeloblast, less in the lymphoblast. Okay, same thing is written over here. No need to go over that again. Okay, चलो जी आगे बढ़ते हैं. Can you identify whether it is lymphoblast or myeloblast? And there is another diagram. Identify diagram A and diagram B. Whether it is lymphoblast or myeloblast. Tell me diagram A and diagram B. First of all, tell me A कौन सा है and then tell me B कौन सा है. A and B. Yes. I got the answer from you guys. Both of them are myeloblast. I told you that never ever forget. You can see many OR rods are present. ऐसे करके many net shaped OR rods are present over there. So this cannot be any other than the myeloblast, and both the slides are shown in the FMG exam, one in 2019 and one in 2021. So please remember, whatever the case might be, if they give you this type of diagrams, yes, absolutely right. So you can see that there are many OR rods. So both of them are the myeloblast and not the lymphoblast, right? Let's move on to the specific stains. So what are the specific stains that are going to be present? So first thing first, lymphoblast, myeloblast. M for myeloblast, M for MPO stain, that is myeloperoxidase stain. Lymphoblast mein P comes more often, right? So MPO, that is myeloperoxidase, M for M, that is the myeloblast ka specific stain. That means if the myeloperoxidase positive, big question will come. Somewhere in that question will be written myeloperoxidase positive. It is again myeloblast and not the lymphoblast. PP, that means periodic acid shift. I'm writing over here, periodic acid shift. If periodic acid shift positive is written, that means it is lymphoblast and not the myeloblast. And there is one more thing that it shows, that is it shows block positivity. What is block positivity? I'll show you in the slide later on. And please remember, there is one more stain, Sudan black B. One more stain is there for the myeloblast, that is NSE, but it only shows the monoblast and not other type of myeloid linear cell. Okay, mono means monocyte agar ban raha hoga tabhi only monoblasts, the cells which form the monocyte, only they can show the NSE and not the other things. Okay, so if they have written over there that NSE, that is non-specific.
Hello to everyone. How are you all? So I just came to say hello to everyone, okay, who's watching the class, and I'm very happy. Okay, अच्छा मैं देखना भी में वो देखना एडजस्ट करना कैमरा नहीं वो उसमें शायद देर से आता है, वो आ गया होगा. हाउ आर यू ऑल डूइंग गुड? देखो बच्चे ना बच्चे, हेलो सर, हेलो. सो आई होप यू ऑल आर डूइंग वेल एंड वाओ क्या बात है, all are replying. ठीक है, I was also watching, so I just came. So I'm coming to Jaipur. Those who want to come, they can come meet me in Jaipur tomorrow 10 a.m. And I hope you all doing well. And do wish ma'am, okay, she had birthday, okay. So हो गया. So yes, we'll wish Dr. Pooja happy birthday and thanks for taking a session, because hematology will give you 4 to 5 MCQs and all will be solved by this. Okay, most welcome. Okay, बस बढ़िया से मैम का चैनल भी सब्सक्राइब करना है. ठीक है, आप प्लीज़ उनको अपना इंस्टाग्राम और हाँ ठीक है, बिकॉज मैम इज़ गोइंग टू टेक मोर सेशन एंड शी विल बी देयर विद अस टिल द वेरी एंड. होपफुली एग्जाम डे भी चलेंगी मैम हमारे साथ. ठीक है, सो आई वांट ऑल ऑफ यू. ये देखो आ गए ना हैप्पी बर्थडे. चलो आई विल टेक सेशन आई थिंक ऑन 8th. माई सेशन विल बी ऑन 8th. मैम विल टेक टुमारो ऑल्सो एंड देन विल प्लान मोर. ओके, चलो बेस्ट ऑफ लक, टेक केयर, कीप स्टडिंग. ओके
चलो, थैंक यू एवरीवन, थैंक यू. हो गया, बर्थडे हो गया. लेट्स फोकस ऑन द स्टेन्स, है ना. Let's focus on the stains. Thank you guys, thank you. My true birthday gift will be if you all pass, है ना, and after passing you will tell me that ma'am, this question came from the lymphoblast and myeloblast and from this questions, right, this topic that you taught, है ना, that is going to be my gift, है ना. So please focus over here, right. So chalo, okay, yes, sir will come in Jaipur. Okay, fine, chalo, let's start and come back. Okay, this 2 minutes ka fun is there, right, and let's come back. Okay, these many people are wishing me, thank you so much, and that's why maybe there is some extra happiness, right. Chalo, coming to the another stain for the lymphoblast, that is, I told you PP comes in the lympho. So please remember, if it is starting from P or PH even, so please remember, if somewhere in the question it is written that acid phosphatase is present, then it cannot be other than the lymphoblast cells. And especially, please remember, B lymphocyte never shows this acid phosphatase say reaction. So only the reaction for the acid phosphatase, that means the stain which is picked up and that is showing the color, that is shown by the T type of lymphoblast. Okay, so please remember, phosphatase agar kahin pe hai or PAS is there, so that is going to be the lymphoblast, right? Now, can you identify what is it? What is this? So there are various blocks which are present. The stain is not distributed equally. It is showing block like thing. So this is block positivity, right? So this over here, what is shown is the block positivity. Can you see that? So in the periphery, in the cells, we can see the block positivity, right? So fine. So in which cells we can see the block positivity? Can you name the cell, lymphoblast or myeloblast? In the block positivity, it is going to be the lymphoblast, right? Right, hai na? I don't know from where the chappal came in between, but anyways, chalo, leukemia and lymphoma. Leukemia and lymphoma. Chalo guys, focus over here. Now we are going to start with the true leukemia, lymphoma. Obviously, the stains are going to be used as a hint, so you cannot forget the stain, you cannot forget the OR rod cells, right? And there is something known as the multiple OR rods. Not only one OR rod, but multiple OR rods are present. Then what that cell is called as? It can be used as your hint also. Okay, so you are going to tell me what it called as, because again I have the slide for that also. All right, so let's start with the leukemia and lymphoma. Please 100% attention, है ना? Fun के time पे fun करेंगे, right? Okay, so leukemia, obviously it comes in the blood and they are of two types. Lymphoid भी हो सकते हैं, myeloid भी हो सकते हैं, depending on whether they are acute, that means the duration is short, right? Last 1 year, last 2 years से अगर हो रहा है तो, or it is there since last 8 years, right? So whether it is prolonged or a short duration, depending on the duration, it is divided into two types, depending on whether it is lymphoid lineage or myeloid lineage. They are again divided into two types. So let's see them. Myeloid lineage and lymphoid lineage, there are two types of lineage. Depending on the duration, we can call it as acute myeloid leukemia, right? And chronic myeloid leukemia. So short में क्या बोलते हैं हम इसको? AML, and we call it as CML, right? So acute myeloid leukemia and the chronic myeloid leukemia. Since we are talking over here in the blood, not in the organs, okay? And in the leukemia, that means lymphoid lineage come into the blood. We are going to again call them as leukemia. We cannot call them as a lymphoma. Why? Because they are coming in the blood and not in the solid organs. So if they are coming in the blood, what you are going to call acute hai. So please remember, when there is acute thing, it doesn't get much of the time to proliferate. So as soon as there are blast cells are produced, they are going to come into the blood. So please pay attention over here to the name. This is known as acute lymphoblastic leukemia. As soon as blast cells are formed, they are going to come into the blood. So that's why it is called as lymphoblastic leukemia. And if it is a prolonged time tumor, so please remember, it does take time, and then not the blast but actually lymphocyte which are matured, so they are going to come into the blood in a higher number. So this is known as lymphocytic leukemia. Okay, so yes, ALL will be there and the CLL will be there. Okay, nobody is going to ask you per se in the detail. Definitely for the NEET PG and all, they ask what is the difference between ALL and AML. Blastic cell comes in the blood. Then usually it is acute, we know that. And if the lymphoblast numbers are not increased, but lymphocyte numbers are increased, definitely it cannot be acute. It takes time to get mature. So please remember by that it is going to be CLL, right? So these are the 4 types of leukemias. Coming to the lymphomas, usually there are 2 types of lymphoma. Everyone knows about it. What are the 2 types, guys? What are the 2 types of lymphoma? So they are the Hodgkin's lymphoma and non-Hodgkin lymphoma. Everybody knows about it, right? And we are going to learn today all of them. Okay. So let's start with the first slide, that is this. Normally you can see like this, and in the leukemia you are going to see something like this. So what is the difference? I told you in the beginning, what are the normal counts? Normal counts of the RBCs are in millions. So if you count the one go over here, so usually one cell of the lymphocyte, of the monocyte, and the 700, in the background you can see 700, usually 500 to 700 RBCs, okay, because their ratio is going to be much higher. RBCs are of smaller size, so usually in the normal healthy person, this is what is going to be look like. But if this is leukemia, that means the leukocytes are increased. Can you see the ratio is drastically changed? Almost the ratio is 1:1 or even less than that. So that means the leukocytes are much more. So you are going to see something like this, okay? So first thing first. And Hodgkin lymphoma, there is one owl type cell is going to be seen, which is known as Reed-Sternberg cell. अगर Reed-Sternberg कहीं पे भी लिखा हुआ है, at least in, suppose there is a ratio of this question also 3:5. क्या है, 5 बारी एग्जाम हुआ है तो they have given this owl appearance or Reed-Sternberg cell, or they have given the peripheral smear in the 3 FMG exam. I have seen the papers, so I was looking at it. So at least 3 in out of 5 exam they have given this Reed-Sternberg cell. Important, very important. This is going to be the Hodgkin's lymphoma, right? I'm going to ask you later on also. Let's start with the leukemia. How many types of leukemia? 4 types, but depending on the duration, there are of 2 types. What are the 2 types of leukemia depending on the duration? It can be acute, it can be chronic. So we are going to divide first of all in the acute and chronic. Let's see how we are going to move ahead with this. So 3 things I want you to know. First of all, how to differentiate between. They are going to give you the hint. First of all, question is there, that means बनाने वाले ने कुछ सोच के बनाया है, right? The examiner must have think of something. So hints are going to be there. You just need to search the hints and identify which are matching with the option. Okay, so first thing, they can give you in the question, big question will be there, in somewhere it is written as more than 20% blast. And it cannot be the chronic one. I told you that chronic takes time, so mature cells are going to be much more, not the blast cell. Blast cells are many much immature cells. Okay, blasts are formed directly from the hematopoietic stem cell, है ना? So blast comes out from the hematopoietic stem cell. So chronic में क्या होगा? It is going to be less than 20%. Somewhere in the hint it can be given. So very important, especially if they want you to go towards acute. So definitely they will be mentioned that 20% blast cells, more than 20% blast cells are there. Then comes the proliferation. If you have, let's say, you don't have much of the time, right? So what is going to happen? You just proliferate and send that into the blood. No need to mature, right? So mature cells are not there. We do not need any time or energy even for the maturation. So more of the energy will be used in the proliferation. Just produce karo aur de do, right? So that is how the India works, है ना? जितने में हम class लेंगे, India की population almost 1.25 times बढ़ गई होगी, right? So proliferation is going to be much higher. Same happens in the acute type of leukemias, and it is going to be lower in the case of chronic leukemia. What about differentiation? Differentiation means whether from the, let's say, the myeloblast is there. From the myeloblast, whether the eosinophils will be forming, basophils will be forming, or neutrophils will be forming. That is known as the differentiation. We are differentiating these premature cells into the mature cells. So that means maturation is occurring. Where the differentiation will be poor? Can you guess me? Yes, please. Please tell me where the differentiation is going to be poor on the basis of these 2 informations. Basis of these 2 points, can you tell me where the differentiation is going to be poor? Maturation is going to be. Differentiation is nothing but maturation. More mature, but yeah, comparatively more maturity. है ना? So acute में, if it is less time, so definitely it is going to be, yes, you guys are rocking. Jyoti, Yahya, Arefa, Purnima, wonderful. So it is going to be poor and it is going to be better, comparatively better or higher in case of a good differentiation is going to be there in the chronic phase. Okay. Let's start with the AML. है ना, background में music होना चाहिए था. Let's start with the AML. So AML myeloid से होगा कि lymphoid से होगा? Obviously, AML, that is myeloid leukemia. So myeloid se hoga, and we can see the myeloblast. I told you blast in the blood is leukemia. Blast in the blood. Can you tell me what age the patient will be? Acute hai, and usually remember myeloids are going to be towards the higher age, right? Especially after the 35 age, but definitely when we talk in terms of acute, myeloid may, they will never give you a case scenario of children. If the children comes, that means it must be especially the ALL. Okay, so the age is going to be 45 to 55. Okay, the age is going to be 45 to 65. And can you tell me what is the pathophysiology over here? Myeloid leukemia, that means maturation is not happening. If something happens in our body also, some immature cells come in the blood, that happens. In the daily life also this happens. But we do not have leukemia. Why is it so? What we have something special because of which this is not going to happen? Tell me. Can you think of anything because of which usually, even if the immature cell come in our blood, we do not get leukemia? Why is it so? Why is it so? Because we do have protective mechanism. Our macrophages are there. Our apoptosis is going to be activated. So definitely, if some immature cells come in my blood, supposing that I'm healthy, I'm not having any leukemia, so what is going to happen? That cell will be apoptosized automatically. I do not need to do anything. My blood, my cells will take care of themselves automatically, which is not there in the tumor cells. So please remember, what is the pathophysiology? That there is anti-apoptosis. That means apoptosis is what? Suicide. Suicide, that means the things which we do not want, they die so as to make us survive more, right? So anti-apoptotic gene is going to be increased over here. So whatever anti-apoptotic factors are there, genes are there, so you can write rather factors, they are going to increase, right? So even if these cells, these immature cells, they are abnormal if they are coming in the blood, but since they are having a lot of anti-apoptotic gene, apoptosis won't take place. So please remember, that is the main pathophysiology over here. It can be genetic or acquired. Obviously, if it is 45 to 65, most probably they are going to give you the acquired scenario. Okay, and mutation will occur, and that will inhibit the maturation of the cell, and that's why the blast are going to come into the blood, right? So maturation won't occur. I told you, acute may no maturation or very poor differentiation, right? With that, let's move on further. Okay, AML में cytogenetics. What are the cytogenetics which are going to be present? Very, very, very important. Okay, so please make as many stars you want, and please make a note or make say out loud over there, what are these cytogenetics? What are the genes that are involved, or how we are going to identify whether it is AML or ALL? You have to revise them many times. And अगर कोई नींद में भी पूछे, if someone wakes you up from the sleep and ask you, tell me whether it is AML or ALL, if there is 922 of mutation, T9:22 mutation, right? You should be able to tell whether it is AML or CML, right? So cytogenetics mein important first thing is M2, M3, M4. What is it? We'll see that. That is something known as FAP. classification, French, American, British, है ना, no Indian, because we are busy in commenting someone, किसी का नाम क्या है, break कब मिलेगा, all that, right? Till that time, the French people, American people, British people, they are making many progress, right? So please focus here. So M2, M3, M4. Cytogenetics. The fab classification, we'll see that, but important one is over here. So how it is written, please make a note that T is written, that means it is translocation. Location change kar liya. So the location is changing, that means translocation. T for translocation, and this in for inversion. So please remember inversion. That means suppose this is the, I'll make some, okay. So this is one arm of the chromosome, this is another arm. What is going to happen? Inversion means the chromosome remains same, but the arms will be changing their position, okay? But it is, what do you think? Translocation or the inversion is more dangerous? What do you mean by translocation? Suppose this is, let's say, okay, I'll make like this, okay? So let's say this is chromosome number 8 and this is chromosome number 21. Obviously the 21 will be smaller. Why? Because we go, as we do the karyotyping, we go from the largest to the smallest one. So 8 number is going to be larger as compared to the 21, right? So if, let's say, it should have been only on the 8, but it came on to the 21. So that means from the 8, that specific gene is transferred to 21, and definitely there is fusion is going to occur, and these genes are important to form some proteins. If they go somewhere else and they form some fusion, some third thing is going to take place, right? So that is means translocation. Definitely if the inversions occur, that is going to be least least dangerous, because again the inversion is occurring but there is no fusion with any other thing, so it is going to be least dangerous. Translocation is going to be dangerous. Why? Because some third thing is forming, or that enzyme is having some abnormality, and that is going to create the leukemias. So please remember, most dangerous is going to be T8 is to 21. Then you have to remember 15 is to 17 and inversion 16. 4 into 4 is 16. So please remember in M4 you are going to have the inversion 16. Otherwise both of them are translocation. 8 is to 21 and 15 is to 17. 15 is to 17. So this is cytogenetics related. The things which I'm showing you, this is known as WHO classification, which is not that famous but again important. Okay, therapy related. That means you wanted to treat something and you started the treatment of, let's say, anything, and in surprise the patient got the AML. So this is going to be the worst scenario. Why? Because you wanted to treat X disease and you gave AML, right? We do not want to be like those doctors, right? Sometimes it happens that somehow this stem cells, they are stimulated or some mutation occurs in them, some gene get affected due to the therapy. Therapy means whatever treatment we are giving, right? So if you wanted to give treatment to some disease and with that the AML occurs, and this is going to be worst. Why? Because you wanted to treat some other thing, but in gift you gave him what thing? The therapy related AML. Then comes the MDS. What do you mean by MDS over here? Can anybody tell me why are looking at the gene, that is 5q and 7q? They are going to be affected over here, and this is, trust me, this is the worst, है ना? Someone says the medicine padhai is worse. No, you have not seen the MDS, right? Why I'm stressing it this, like many a time this question is asked, you have to remember 5q and 7q. Okay, 5q and 7q, these are the worst, है ना? If someone says that there is war going on and many bad things are happening here and there, that is the worst, you said no, MDS is worst, है ना? That many times you have to revise that, you should be getting it within your conversation, right? So 5q and 7q, again I'm going to ask that when we are going to read MDS. Nobody told me what is MDS. What is MDS, bacho? What is MDS? Chalo, I'll write it because I'm not getting any answer. Maybe it is stuck or I don't know what. Myelo, it is myelodysplastic. Aplasia is good, not the dysplasia. Dysplasia is even worse than the aplasia. Okay, myelodysplastic syndrome. So please remember, please remember, this is the worst. Yes, therapy related are the worst, but these are also bad. What I'm saying you is this mutations are the worst. If 5q and 7q mutations are given, in the mutation, definitely the MDS mutation is the worst. And in the scenario per se, the therapy related is going to be the worst. Okay. Chalo ji. Let's move on to the next thing. What is the hallmark of this? That you have to identify whether it is AML, ALL or CLL or something else, right? So hallmark, if you see something in the cell, I showed you already those cells. If you see those cells with that hallmark thing, which is not going to be present in the lymphoblast and all, so you are going to say that yes, it cannot be any other thing than the AML. And what is that, Petro? What is that? Suppose if I draw a cell over here, then I show you the nucleus and nucleoli, and I have something like this. What is the hallmark? Yes, Ragnar, right, and Dr. S. So you guys are absolutely wonderful. The OR rods, if you see the OR rod, definitely they are pointing you towards the AML. So please make a note of it. OR rods, if they are there, then it is going to be the myeloblast. Usually it is going to be the AML, right? Because I told you granules, much more granules will be there. They are going to precipitate together, going to form OR rods. So acute hai, so no differentiation. More earlier the cell, more will be the granules, and they are visible ones, and they are going to form the OR rods. So chances are less in the CML. Let's move on to AML. Now, write with me M1, M0, M1, M2, M3, M4, M5, M6 and M7. The easier ones, we are going to take it out. 6. 6 ko if I just turn it upside down and I just reverse it, so it looks something like this, right? So 6 looks something like this. So please remember, 6 is nothing but erythrocytic, okay? Erythrocytic. So this is going to be the erythrocytic. 7 is the largest number over here. So who are the largest cell in the bone marrow? So erythroblastic or erythrocytic you can write, and this is mega. Mega is bigger number, so please write it down. Megakaryocytic. Megakaryocytic is going to be the M7, largest number, okay? M7 is very, very important. It causes one syndrome. If you can tell me, I'll be more than happy. Okay, which syndrome it is going to cause, because again, we are going to learn that in the later on stages. Faraz, Dr. Sonu, wonderful, wonderful, Medvision, Osama also, right? So then we are going to move on to these 5 things which are remaining over there. They are all related to either myeloblast or monocytes, okay? M0, as we are going to go down, there is going to be more maturation and more differentiation. So please remember, first of all, there is no. 0 means no differentiation. So please make a note of it, no differentiation. No differentiation. Downs, yes. Dr. Amir, Payal, Purnima, Dr. Fit, Ashwini, yes, you guys are rocking. So this is going to be related with Down syndrome. Okay. Now, coming to the M0, M0, 0 means no differentiation. No differentiation, okay. M1, obviously we are going towards maturity, so we want differentiation, hai na? So differentiation will be present, but there is going to be no maturation, low or little maturation. Or we can write without maturation also. Differentiation hua, maturation nahi hua. Let's move on a bit further. M2 is going to be with maturation. So without maturation, but with differentiation, that is M1, then comes with maturation. With maturation. And M3, it is going to be promyelocytic. So please make a note of it. Now the differentiation maturation has been done. So M3 is going to be acute promyelocytic leukemia. I'm not writing acute because again we are discussing about AML, so everything will be acute. Okay, acute myelocytic, acute erythrocytic, acute megakaryocytic. I'm not writing that. Okay, acute promyelocytic. Pro में 3 words are coming, so please remember. I used to remember that case, so please remember promyelocytic leukemia. That is going to be M3. Can you tell me there is 3-word things or the short form is written in the 3 alphabets which are related to M3, and what is that? You guys can tell me. M4. M4 is after a promyelocytic. What was there? Myelocytic, and then comes the metamyelocytic. So please make a note of it. The acute myelomonocytic are going to be the M4, and acute monocytic. It is not myelocyte, it is monocyte. So please remember there is a difference. Myelo is the premature ones. Yes, you guys are rocking. So this is DIC related. Can you tell me M5 also now? Acute, what I was writing, monocytic. Acute monocytic is going to be there. Yes. Disseminated intravascular coagulopathy, that is related to 3-3RF. So please remember M3 is related to DIC. Okay, M3 is related to DIC. M5 is related to gum hypertrophy. Yes, Nida, if you remember all of this thing and you solve some question, definitely you are going to solve all the questions of the Hemat for sure, guaranteed. The first thing I told you, that have a faith and listen to the class properly and revise it at least 2 to 3 times before going to the exam. One revision you have to do like tomorrow or day after tomorrow, and then wherever you are planning to do the next revision, at least 2 revisions you should do. Okay, chalo. Which one of these were most common? M1, M2, M3, M4, M5. Yes, gingival hyperplasia, right? So tell me, what is going to be, which one of that FAB classification is most common, where the OR rods are not seen? If the OR rods are not seen, so that is going to be the M2. Please remember the M2 is most common. Okay, so M2 is most common. Then comes the M3, maximum OR rods are there in the M3, and the DIC is associated with M3. We discussed that, right? M3 may we call it as, what was the M3? Acute promyelocytic leukemia. Now we do have 4-letter treatment for it also. If you can tell me the treatment for it. Yes, please. It starts with also A and it is also containing 4 alphabet. And what is that? Can you tell me? Yes, Dr. Felt, you're absolutely right. That is ATRA. That is all trans retinoic acid. We give the vitamin A basically. It is the concentrated form of vitamin A, ATRA. We give it in the M3. Okay, let's move on. M4 and M5, they are going to be non-specific HOAs. For the myeloblast, which stain I told you? Myeloblast ke liye, what stain I told you? Usually the MPO is going to be positive, but remember NSE is also going to be positive for M4 and M5. Okay, so please make a note of it. And M5 is going to be related with the gum hyperplasia. You can call it as gingival hypertrophy also. So gingival hypertrophy or hyperplasia. Hyperplasia is again going to cause the bigger things, that is gum hypertrophy. You can call it as hypertrophy also. Gum hypertrophy or gingival hyperplasia. Coming to the next thing, that is M7. You guys already told me M7, very, very important. If you want to remember one thing from this slide, obviously the whole slide is important, but if you want to just remember one thing, so please remember M7, that is going to be associated with Down syndrome. The bigger one, that is Down syndrome. Okay, most important one. Chalo, let's move on to the next. Clinical features. Coming to the bone marrow infiltration. What can be the clinical feature? With what symptoms the patient is going to come to you? Obviously, what is happening? There was a bone, right? In the bone, we had marrow, right? In the bone, we had marrow. And in that marrow, first of all, the normal marrow was producing all type of cells, right? Like RBCs, WBCs, platelets. But now, most of the energy is used to produce WBCs. But they are not even WBCs, they are immature WBCs. So this marrow was the factory for all the blood type. But now the marrow is only producing immature cells. And which cells are those? The WBCs. Immature WBCs are produced. So that means what is going to happen to the RBC count and the platelet counts? Tell me, what is going to happen to those counts? RBC, WBCs and platelets. So what is going to happen to the RBC count? Definitely the RBC count is going to decrease. And if the RBC is decreased, that means hemoglobin production is also decreased. Hemoglobin production is decreased. What do you call it as? Anemia. So patient is going to come to you with the symptoms of anemia, not that he's going to tell you that I'm having anemia, but he's going to come to you with the symptoms of anemia. And what are the symptoms of anemia, bacho? Yes, please, he can come to you with the pallor because hemoglobin is less. That means the color of the skin is going to be not pinkish, it is going to be pale, right? Anemia is going to be there. Yes, pallor. Then oxygen, he's not getting a proper oxygen, so less energy. Fatigue will be there, easier fatigability, right? So pallor, fatigue, and with that he can have the dyspnea on walking or stressful exertional situation, right? If he exert or walk on the stairs, he can have the condition that is nothing but the difficulty in the breathing, dyspnea. Okay, so pallor, fatigue and dyspnea, these can be the symptoms. WBC, what will happen to the WBC count and what will happen to the platelet count? I told you that there are immature WBCs which are produced excessively. So this becomes the factory of immature WBCs. So definitely hypercellular bone marrow is there. The WBC counts are increased, but please remember these are not the mature cells, right? Maturity kuch nahi hai na? So what are they? They are immature cell, and that's why immaturity is harmful sometimes, है ना? Many times it is going to be harmful. Platelets number, are they increased? No, they are going to decrease. The WBC count is going to be increased. Platelet numbers are going to be decreased. What we call that as thrombocytes. So thrombocytopenia is going to be your decrease in the platelet count. Thrombocytopenia, what is the function of platelet? Function, where the platelets are important? To stop the bleeding or to maintain the blood flow. That is known as hemostasis. So if the thrombocytes are less, will the hemostasis occur? No. The stoppage of blood loss will not occur, right? So there is no hemostasis or very less hemostasis, or it will take more time to form the clot in the blood. So that's why, please remember what is going to happen. The patient can come to you as the symptom or with the symptom of bleeding disorder. Various bleeding disorders are there, purpura, ITP and all those petechiae, all those symptoms. With that, the patient can come to you, right? Yes, you guys are rocking. Superb. So one thing, the examiner can mention easy bruisability. What is easy bruisability? Bruise. That means if you have some blunt trauma, you get bruise. But without any blunt trauma, if the patient is getting bruises, for example, he slept for one day and at the back, if he's having bruises, that means the pressure was applied on his back while sleeping. Normally, we do not have the bruises, but as soon as he wakes up in the morning, he can see the bruises in the back or the pressure area. Suppose he is sitting long for like this. So here having the bruises over here. So that is easy bruisability that you have to see that. That means the platelet counts are less. Okay. Coming to the organ infiltration, I told you leukemia can go into the organs also. If it goes into the organ, definitely it can go in the bone, it can go in the lymph node, and it can go in the other organs also. So what if it is going in the bone, right? In the medulla it is produced, but in the cortical area, it can go and lodge there. It will start taking the nutrition from there, and rather than providing the nutrition to the osteocyte, we are providing the nutrition to the tumor cells. So what is going to happen? Definitely the osteocyte will be weak, there will be osteoporosis, and the patient can tell you the pain and tenderness in the bone, right? As soon as you touch the bone, the patient may have the pain, that is the tenderness. In the lymph node, the swelling can be there because the tumorous cells are growing. So that is known as lymphadenopathy. Lymphadenopathy can be seen in the patient. Other organs, what is going to happen if it goes in the liver? It lodges there and start to proliferate. The size of the liver, the size of the spleen will increase, which we call it as hepatosplenomegaly. Easy? Very easy, right? So the examiner can give you this. All these symptoms can be seen, and yes, it can involve the CNS also. Definitely it won't involve the brain per se. Why? Because we are having the blood-brain barrier around it, but the meninges are the covering. They can get into the covering, that is meningeal dura mater, pia mater, arachnoid matter, and they can start proliferating there. So meningeal involvement can be there. Can you identify these cells here? Can you identify? You already did. So these are shown. That means this is the OR rod cells. But there is not a single OR rod, right? There are many OR rod, and what we call it as? What we call it as? If the multiple OR rods are there, we call it as? Okay, I'm getting very late replies, so I'm moving ahead. It is called it as fagot cell. Okay. Alright, so this is known as fagot cell. If multiple OR rods are seen, it is known as fagot cell. So this particular name can be given in the question also. So read the question carefully and try to find out the hints. Okay, fagot cell. Right, maximum in the M3. Good. चलो जी आगे बढ़ते हैं. Immunophenotyping. In that AML, if we talk about AML, what I told you, CD marker क्या होता है? Myelocytes are increasing. What I told you, M अगर आप tilt करो, so it looks like 3. So I told you the CD marker for this. What was the CD marker for myeloid cell? That is going to be increase, much increase in the myeloid AML, that is myeloid leukemia. And M7 में एक CD marker मिलता है. M7 में तो I'm going to tell you that is 41 and 42. 41 and 42 is related to this M7. Down syndrome में you are going to see this. Yes, you guys are absolutely right. That is 33. 33 is going to be for myeloid, and M7 के लिए please make a note 41 and 42. Okay. Sure. Let's move ahead. Let's come to the treatment part. Treatment part is going to be bone marrow transplant, or if it is M3, we already talked about the ATRA. ATRA is all trans retinoic acid. It is the concentrated form of vitamin A. है ना, कुछ नहीं है, विटामिन ए का ही कॉन्सेंट्रेटेड फॉर्म है. यू मस्ट हैव लर्न दैट इन द स्पेशल सेंसेस. आंख में पढ़ा होगा आपने कि ऑल ट्रांस और सिस रेटिनिन होता है, फिर ऑल ट्रांस लाइट पढ़ने पे वो ट्रांस में कन्वर्ट हो जाता है. ऑल दीज थिंग्स है ना. 11 सिस कन्वर्ट्स इनटू द ऑल ट्रांस, राइट? यू मस्ट हैव लर्न इन द फिजियोलॉजी और ऑफ्थल्मोलॉजी. चलो जी, ट्रीटमेंट ऑफ चॉइस ऑलवेज. बोन मैरो में प्रॉब्लम है, चेंज कर दो, है ना. सो दैट इज हाउ वी वर्क, है ना. जिसमें प्रॉब्लम है वो हटा दो और नया लगा दो. सो दैट इज गोइंग टू बी अवेलेबल नाउ. दैट इज बोन मैरो ट्रांसप्लांट. ऑलवेज द ट्रीटमेंट ऑप्शन फॉर द माइलॉइड ल्यूकेमिया आर गोइंग टू बी, ट्रीटमेंट ऑफ चॉइस इज गोइंग टू बी बोन मैरो ट्रांसप्लांट. व्हाट इफ इट इज नॉट अवेलेबल? At that time we cannot find a proper genetic match for that person. Are we going to leave that like this, or we are going to give another therapy which is known as CAT therapy? What is CAT therapy? There are 3 drugs which we can give in the AML. I don't know whether it is going to be asked or not. Usually they ask the question on it, but this is the extra information. If you want to remember, you can. Otherwise you can just leave it. Cytosine, arabinocyte, cytosine arabinocyte, then comes the anthracyclines. Can you tell me the name of anthracyclines? And then comes the 6 thioguanine. Thioguanine. Okay, so this is a CAT therapy. If the bone marrow transplant is not available, or the person cannot afford the bone marrow transplant, or the age is much higher, we cannot afford to do any surgery, right? So in that case, we give this CAT therapy. What is the CAT therapy? That is nothing but the cytosine arabinocyte. Then comes your A, that is the anthracycline. Yes, you guys are right, donorubicins, है ना? So how I used to remember, two drugs are preferred over here, DAT, है ना? DAD, that is donorubicin. First is that, and the second one is adriamycin. So DA and AD, that is adriamycin. Adriamycin, donorubicin and adriamycin, these two drugs are preferred. I hope it is done in the pharmac also, right? These donorubicin and adriamycin specially chose for this AML. All right, let's move on. So that is all about the AML. CML is more important. Can you tell me the cytogenetic change that occurs over here? If you tell me, then that is there. Before going to the CML, we are going to learn about the myeloproliferative disorders. This is not the CML because I have nowhere mentioned it as the leukemia. Rather, I am talking about chronic. Yes, it is chronic from the prolonged duration. Myedo means something happening in the myeloid this lineage, and proliferating. Myeloids are proliferating. Maybe that is leukemia, maybe not. So in that, under this condition comes the leukemia. That is the chronic myeloid leukemia. It can be polycythemia vera. It can be essential thrombocythemia or thrombasthenia, or you can write, even in some books it is written as thrombocythemia, essential thrombasthenia or thrombocythemia, and primary myelofibrosis. Okay, so we are going to make a chart of it. You guys are good. Arkdeep, Faraz, Payal, yes. The 922, that is Philadelphia chromosome. We cannot, if you want to remember only one cytogenetics, please remember Philadelphia chromosome, asked many a times in all the type of exams. Okay, so let's make a chart of it. That is this one. CML we are going to talk a little bit in the detail, and these three conditions just we are going to wave it off like this. Okay, so cytogenetics in the CML, you guys told me Philadelphia chromosome. What is the mutation over here? Please remember, in all of these we do have a mutation which is known as JAK2 mutation. Over here also JAK2, over here also JAK2 mutation. So please remember, in all of them JAK2 mutation will be there except CML. CML में Philadelphia chromosome is seen. Okay, there is no JAK2 mutation. वहाँ पे tyrosine kinase की activity change हो जाती है. Okay, so for now just remember JAK2 mutation is there in other three condition. What was PV? Polycythemia vera. इसमें RBCs बढ़ जाते हैं. Okay, so please remember RBCs are going to rise over here, and thrombocythemia, that means over here the platelets are going to rise. CML mein we are going to talk about WBC. Then what is this myelofibrosis? See over here, fibrosis is occurring. That means normal cells are get replaced by the fibroblasts. Fibroblasts are of useless. Why? Because they do not proliferate, they do not have elasticity or flexibility. They are of no use except the support system. Okay, so whatever thing is damaged, those cells are replaced by the fibroblasts. If it is of no use, then what will happen? Which cells will be increased? All the cell types will be decreasing, and that is known as pancytopenia. That means all the cells will be decreasing over here. BCR aerial, very good, Dr. Fit. Now, what is the hemoglobin level will be in the polycythemia vera? I told you RBCs are increasing. That means in all the RBCs the hemoglobin will be produced. So hemoglobin is also going to rise. Now, for the male and female it is different. In the male, obviously, testosterone stimulates the erythropoietin, which makes more of the hemoglobin. So please make a note of it. If it is more than 16.5 gram percent या per deciliter, then definitely we are going to go towards the polycythemia vera. Okay, and in the females a little bit less, more than 16. If they have given you like 16.3 in the females, definitely you will think of the polycythemia vera. Hematocrit. What is the hematocrit? If you take a blood sample from the venous side, you know, and you transfer it into the test tube, and you let that test tube either to stay like that for hours, or you did the centrifugation, what is going to happen? All the RBCs are going to settle down, then the WBCs and platelets will be there, and then comes the plasma, which is going to be yellowish in color usually. So please remember, all the RBCs are going to settle down, that we are going to see in the RBC side, and this is known as hematocrit or packed cell volume. So if the RBCs are increasing, that means packed cell volume, your hematocrit is also going to increase. Usually, normally it should be how much? Normally it should be 45% of the whole blood. So if you are taking 10 ml of blood, 4.5 ml will be PCV and 5.5 will be your plasma and WBC and other platelets, right? But over here, obviously the RBCs are increasing, that means the hematocrit will increase. Rather than 45, instead of 45 in the males, it is going to be how much? 49% and more than 48%. More than 49% in the male, more than 48% in the female. Erythropoietin. What is going to be happening to the erythropoietin? Now, that depends, right? Erythropoietin levels are going to be normal or even less over here. Why? Because erythropoietin ka, what is the job of erythropoietin? It increases cell. Already the cells are increasing because of the cancer, right? So that's why the erythropoietin will have, these RBC will give the negative feedback. You must have learned in the physiology that it gives negative feedback on the erythropoietin. So erythropoietin either will be of normal or even lesser. So usually we get less erythropoietin levels. And yes, splenomegaly will be there. More RBCs are produced, and those RBCs are going to go in the spleen, more will be the breakdown, and that's why the splenomegaly will take place, right? Coming to the myelofibrosis, fibrosis is there. So if I take bone marrow aspiration, what can I see in the bone marrow aspiration? Yes, please. Yes, Falak, right? So what you're going to see in the aspiration? Fibrosis is there. Will you get anything? No, all the cells are fibrosed, almost the marrow is fibrosed. So you won't be getting much, right? So if I draw like this, that if you are very, very thirsty, and you go and open a tap, you open a tap, but you won't get anything. What do you call it as? Yes, you're going to get everything dried up. So dry tap will be there. Okay, you won't be getting much of the cells. So, and what happens once the fibrosis is there? When fibroblasts are there, for the RBC it is much more difficult. What is difficult? It is much more difficult to, suppose this is the fibroblast, and suppose there are some cells which are traveling in between those fibroblasts, it is much more difficult to get out from that fibrosed marrow. So what happens? Rather than having that proper biconcave circular shape, those RBC change the shape that they become teardrop shape, or this is also known as dacrocyte. While they are moving out from the fibrosed marrow, they change the shape because it's very difficult. So they lose their shape in between while coming in the blood, and they becomes tear shape or dacrocyte. They are also known as dacrocyte. Again, the splenomegaly will be also there. Coming to the platelets, we are not going to talk in detail about the platelets. In the platelets, we are going to talk much more detail in the this platelet wala factor. Okay, so nothing on the bone marrow, nothing happens to the hematocrit, nothing will be happening to the in the peripherals. We won't be getting, rather than increase in the count. Coming to the myelodysplastic syndrome, I told you the most worst type of cytogenetics. What was the worst type of cytogenetics? You can see over here, if I write M like this, and 1, 2, 3, 4, 5. Myelodysplastic, the worst thing, है ना? So worst cytogenetics, 1, 2, 3, 4, 5. Worst cytogenetics is going to be, yes please, which one? Worst cytogenetics or MDS में what you are going to see as a cytogenetics, it is going to be, answer abhi bhi nahi aa raha, yes, Shabas, right? So gene involved is 5q and 7q, you cannot forget this, okay? So 7q and 5q, yes, Yahiya, Purnima, Agdib, good. So please remember, this is very, very, very important. If I'm saying very important, that means I have seen these questions coming alternative year, right? So myelodysplastic syndrome. Primary is going to be primary origin. That means we cannot find something different in the periphery. This is not something acquired. Something happens in the bone marrow itself. The factory got damaged and that's why this happened. But if it is therapy related, that means the marrow was fine. We have given some treatment for some other disease, and because of that viral infection or therapy related, if the patient acquires this dysplastic syndrome, then it will be called as secondary. So primary means automatically, without any therapy, without any infection, if the marrow in the factory itself some defect occur, that we are going to call it as primary. If it is secondary, definitely it is therapy related or some infection related, right? So definitely it is going to having a poor prognosis because we evolved it, right? After giving a treatment, not we per se, something happened because some mutation happened because of the therapy and the patient got this secondary MDS, right? So if it is dysplastic, what can be the symptoms? Aplastic anemia, which we'll discuss tomorrow, PNH, that is paroxysmal nocturnal hemoglobinuria. So I'll just make a note of it. Paroxysmal. Again, we are going to learn that tomorrow. Paroxysmal nocturnal. Nocturnal means in the night. Hemoglobins come in the blood first and then goes to the urine. So if it is hemoglobinuria, if it is coming in the urine, we call it as hemoglobinuria. Okay. Let's see what kind of appearance the MDS is going to have. So can you tell me what it is called as? Right, same type of cell you can see over here. So what this is called as? And you can see that these cells are not per se round, these are oval shaped. So this is going to be ovulocyte, and these cells are not blue, rather they are having red type of cells or red type of nucleus because we have given the hemosiderin over there. The hemosiderin is formed there. So yes, please. Yes, Falak, you are right. So this is spawn ball appearance. This appearance, this if triad is seen, right? So this is known as spawn ball appearance. And RBCs, in the background if you see the RBCs, they are of oval shape, right? They are not round shape. Yes, round shaped are also there, but most of them are oval shape, right? They are not per se a circular shape. So yes, the RBCs will be ovulocyte, and in the WBC what you can see, ring. So what is this? You can see the nucleus in between and some precipitation of the stain in the granules which are covering the nucleus. So it looks as if it is a ring. So it is known as ring sideroblast. Okay, so this is known as ring sideroblast, and perinuclear hemosiderin pigments which are going to accumulate and which are going to take up the stain, and this blue stain over here will form a ring around the nucleus which is known as the ring sideroblast. Okay, and what we talked just now in the megakaryocyte, you can see this is a biggest cell, hai na? So you can see the RBCs in the background. So this is RBC, this is RBC, this is RBC. These are the WBCs which are having double the size of the RBC, but it is much larger, at least 10 times larger than the RBC. This cell is there. I told you this is going to be the megakaryocyte. A typical diagram will be given. This peripheral smear is came in only in 2 exams, right? So please remember, ऐसा कुछ 3 ऐसा बड़ा सा दिखे आपको. So this is none other than the pawn ball appearance, and it is seen in the MDS. Something abnormal, very abnormal, that is dysplastic. Okay. Okay, that is all about MDS. Let's move on to the CML now. Everybody told me, if you want to remember one cytogenetics, please remember the Philadelphia chromosome. right? So that is transmutation or transfer of the ABL BCR gene, that is the Philadelphia chromosome, right? So what is going to happen because of this? The immature granulocytes will be formed, right? And basophilia will be seen and splenomegaly. So in the MBBS students, if we are teaching the pathology, we say that when you are writing the definition itself, in the definition, all those four points should be covered. Okay, so please remember, they will be most of the time, either they are going to give you this Philadelphia chromosome or they can tell you a basophilia, because splenomegaly is common in all of them, right? You can see the splenomegaly in the polycythemia vera also, in the myelofibrosis also. But remember that the Philadelphia chromosome and this the basophilia won't be seen in those cases, but it is seen in the chronic myeloid leukemia. So please remember at least these 2 points, very, very important. If it is written as basophilia, it will be the chronic myeloid, because acute may this cannot happen. Acute may you are never going to get basophil per se, right? You are going to get all the myelocytes or monocyte, myeloblast or monoblast, okay? Right. So can you guess the age of this? Always remember, if something is chronic, so the patient should be chronic. That means the patient should have much more age. So acute can occur in the bachpan, that means in the children. That means the ALL can occur in the children, not the AML. We saw the AML occurs in the 45 to 65. And please remember, the chronic are always seen in the elderly, be that the myelocytic or the lymphocytic leukemias. They are always seen in the elderly patients. So chronic हमेशा elderly में आता है. Then comes this Philadelphia chromosome. ऐसा कुछ दिखाया हुआ है. Suppose this is the 9th chromosome. This is the 22nd. Even if it is not written, you should able to identify how? With the size. As you go forward in the karyotyping, the size of the chromosomes are going to decrease. Okay. And what happened over here? The fusion will take place, and that will stimulate the tyrosine kinase activity, which will form much more proteins, and those proteins are ultimately forming this or giving rise to the CML. Okay, perfect. Geriatric, right? Dr. Fit, elderly, Arifa, Argdeep, Sonu. Yes, it is seen in the old age. Your comments are coming bit late towards me. Maybe this is how it is, right? In the actual scenario, this looks something like this, है ना? ऐसा नहीं दिखेगा, but exam में they will give you this diagram. They won't be giving you this, or either even if they give this diagram, this came in the INICT, not to the FMG students usually, but yes, what they can give, they can mention the name ABL BCR. If you see that is none other than Philadelphia. Philadelphia occurs in the CML only. Okay. Chalo ji, 3 phases are there. If we say we saw the FAB classification in the AML. Over here, there is no classification per se, but there are phases. First, the CAB, we say that first of all, what is going to happen? Chronic phase will occur, then A, that is accelerated phase, and the blast phase. So CAB, please remember phases: chronic, accelerated, and blast phase. So how we are going to differentiate? As soon as it starts, the blast cells will be less. As soon as it grows much more, it starts to proliferate, because whatever blast cells are formed, those also proliferate. So first of all, if you see the blast cells, they will be lesser, but as the phases progress towards the later on phases, definitely the number of blast cells will be increasing, because those blast cell itself will be proliferating. So for example, suppose there was one blast cell which was proliferating and it became tumorous. So what it is going to form 2 or 3 cells. These 3 cells will start forming the blast, right? So first of all, it will be less blast, that means less than 10%, and at the last phase, double than that, that is more than 20%. In between, it is going to be accelerated ones. I told you, please remember basophilia, but basophilia is not seen in the chronic phase of CML, but it can be seen in the accelerated and blast. Usually the patient won't come to you in the chronic phase, but definitely in the accelerated and blast phase, it is going to come to you. Yes, Payal. Right. Now, there is something known as biphenotypic leukemia. Now, what do you mean by biphenotypic? Phenotypes means structure, right? So, there are two things, genotype or phenotype. Phenotype usually related to morphology, right? And the genotypes usually related to gene. You must have studied in the gynecology that, right? So, phenotypic means how it looks like. So, on the looks, we divide these cells into T and B cell markers. Okay, so these cell markers are going to be increased. Please remember, we are talking about myeloid, but the cell markers of T and B lymphocytes are also going to increase over here, right? So please remember, it is written there. So both T and B cell markers are going to be increased. In the CML I'm talking, right? In the blast phase I'm talking. That means now the lymphocytes are also growing. There is no differentiation whatsoever. NAP score is decreased. Now what is this NAP score? I told you that in the CML, myeloid say yes, myeloid say granulocytes will be developed. Now, I told you that more will be the differentiation, lesser will be the granules. Okay, so if you want to identify in which stage it is and you won't be able to get it from the nucleus size, so you see the granules. So, as the cell matures, number of granules will decrease. But over here the blast cells are coming. So, more will be the granules, and more will be the granules. There is something known as the alkaline phosphatase which reacts with these granule, and this is going to give you the color. No need to remember, just remember over here the NAP score is going to be less in the chronic phase. As you go towards blast phase, it is going to increase, right? As a treatment, drug of choice is imatinib. We do have only drug for this, only CML. That means you can use it as a treatment. बोन मैरो ट्रांसप्लांट का इतना जरूरत नहीं पड़ता है बिकॉज द पेशेंट इज ऑलरेडी एल्डरली. इमेटिनिब से काम बन जाता है. The condition is under the control with these drugs. We are very, very thankful to these drugs because again, in the elderly, the bone marrow transplantation is having more risk than the benefit. So definitely we go with the imatinib. Imatinib क्या है बच्चों? It is the, can you tell me what is the imatinib? It is the kinase. I told you tyrosine kinase will be having the altered activity. So it is the kinase inhibitor, not per se tyrosine, but many kinases are inhibited by this. So it is kinase inhibitor which we give over here. So if we inhibit the kinase, the proliferation is decreased. If the proliferation is decreased, the situation comes under control. So we are very, very thankful. There is one more drug, if you just want to make a note of it, hydroxyurea. Now see, we are talking theoretically, but as soon as the patient comes to you and he will come to you with all those symptoms, and the patho people will, you are going to send him towards the patho people will take the bone marrow biopsy, then they will do the biopsy, then they will check it, then the report will be given to you. But you are suspecting that yes, the patient may be having leukemia. You are not just sure which leukemia it is there. Then you are going to give the hydroxyurea. Hydroxyurea you can give in all the blast crisis. You're not sure which type of leukemia or lymphoma it is there. So if you suspect or you see that it is the blast cell, patho people say you on the call that yes, there is some type of leukemic or lymphoblastic cells are there, but we need to confirm. Remember, at least it takes 2 to 3 days to confirm the cytogenetics. क्योंकि वो क्रोमोसोम निकालेंगे, right? First of all, they will take the cell. From the cell, they will go towards the nucleus. From the nucleus, they will take the DNA. From the DNA, they will take the chromosome, right? It's a long process. So to get the report, it takes almost 1 week or so. Okay, in the government setup at least. So till that time, you can start the hydroxyurea. Unless and until you are sure, you can start the hydroxyurea. Okay. Blast crisis mein you can give. And again, treatment of choice mein, always and always bone marrow transplant. Nothing can replace the bone marrow transplant. Bone marrow is defective, so you change it, right? Imatinib say we are going to control the situation, but it is not going to cure the patient. So for the cure, we have to do the bone marrow transplant, right? So I wanted to ask you what type of cells you are going to see over here. Are the lymphocyte, monocyte, neutrophils, basophils, or all of them are there? So it is looking like what thing? Poorly differentiation cell, lymphoid markers. Yes, poorly differentiated cells are there. So yes, Roy, you are right that they will be showing you the B and T cell markers. Okay. Chalo. So what type of appearance is there? All the type of cells are there, right? Lymphoblast, monocyte, the neutrophils, all are there, right? So it is looking like a garden party appearance, right? If you are giving a party, definitely you won't be calling only doctors, right? You will be calling everyone. So it is looking like a garden party appearance. If only lymphoblasts are there, if only neutrophils are increased, so it looks like a uniform type of appearance, but this is not a uniform appearance. Everybody is coming into the blood, so definitely it is looking like more of the garden party appearance, right? You'll be happy to see this, है ना? Because yes, many of you are very happy to see that this is the garden party appearance which we can see in the CML. On the other hand, in the CLL, it is uniform appearance or convent girl appearance, uniform appearance. Yes. So college girl appearance also. So please remember garden party appearance, CML, and the CLL is going to be the uniform appearance. Right. Let's move on. Can you guess what is this? Either it is the uniform appearance or CLL or CML basically. What is it? ML or LL? What you can see over here? Different types of cell. Monocytes are also there, lymphocytes are also there, neutrophils are also there, basophils are also there, है ना? This cell specifically, you cannot appreciate the nucleus, है ना? So ये क्या है? This is basophil, right? So basophilia there. So if you can see the basophil, because you cannot appreciate the nucleus, I can somewhat appreciate the nucleus, but not exactly. So definitely it is CML. Okay. So please remember, ऐसे बहुत सारे cells दिखे हैं and you are not able to identify कि किस cell को देखना है, neutrophil भी है, lymphocyte भी है, basophil भी है, सब कुछ है, CML. Okay. Let's move on to the next thing, that WBCs. Now you can see over here what type of cell this is. Either it is neutrophil or lymphocyte or eosinophil. What is it? Yes. Gerald, Salil, keep the legacy. Ra Verma, yes. Dr. Solu, all of you are right. Yes, these are neutrophil. Why? Because you cannot say them as eosinophil because you have to see whether the pinkish red granules are present or not. So these are neutrophil. Usually in the blood, either N3, that means 3-lobe neutrophil, 4-lobe, 5-lobe. Usually they are going to give either 4 or 5-lobe. But if this is there, so this is known as hyposegmented, and that too not a single one. There are multiple, right? 2 or 3 hyposegmented neutrophil are given. So these are the hyposegmented neutrophil. Where you are going to find this? There is an anomaly which is known as Palger-Hewitt anomaly or pseudo Palger-Hewitt anomaly. Biload headphone, but yes, headphone usually seen in the eosinophil, not in the neutrophil. But if the granules are not brick red color granules or pink red granules, you cannot say it as eosinophil. Definitely you guys are right that it is the neutrophil, but only 2 lobes. So definitely it is going to be the neutrophil and Palger-Hewitt or pseudo Palger-Hewitt. Yes, Roy, you are right. So this is Palger-Hewitt or pseudo. Pseudo में क्या है? Pseudo is acquired. Palger-Hewitt is genetic. Mostly it is genetic. If it is acquired because of some infection, treatment or something like that, then you are going to call it as pseudo. It is not real, right? It is not genetic. It is not within that person. We have invented it, right? So because of any infection or because of any mutation after the birth, it is not genetic, it is not present in their parents or grandparents, but definitely it is there in them, and this is associated with MDS and CML. This question usually comes again. They can directly give you the correlation of MDS, or they can give that it is associated with the mutation of 5q and 7q, right? That means again it is related to MDS. Okay, so please remember this is going to be pseudo Hewitt anomaly. Okay, hyposegmented. Can you tell me where the hypersegmented neutrophils are seen, which we are going to cover later on tomorrow, not today, right? Yes, you already told me. Muraj, absolutely wonderful. You are going to see what thing? You're going to see the hypersegmented in the megaloblastic anemia. Tomorrow we'll cover that. Chalo, aate hai good prognosis, bad prognosis. We are starting with the ALL, that is acute lymphoblastic leukemia. Okay, lymphoblast. It is having less time, no time for the maturation, so it comes into the blood, and that's why leukemia, lymphoblastic leukemia. And yes, B12, right. B9 also. And ALL mein what is going to happen? Good and bad. Usually girls are good or boys are good? Usually both are good if they are doctors, but yes, girls are more good, right? So G for girls. So that's how. Obviously I am a girl, so girls are good, right? So B for boys, and they are bad boys. Boys want to be bad, right? So bad boys. So please remember, if we talk about age, what is the age? If it is occurring in the children, it is going to be good or bad? Tell me. It is going to be good or bad? What about the age? If it is occurring below 2 years, that means in the infants, definitely in the infants, it won't stop, and the maturity of other organs is much less, and you start the chemotherapy below 2 years. You can imagine what can happen in the children, right? So this is going to be less than 2 years or more than 10 years. It is going to be good, right? Usually chemotherapy works on them, right? So it is going to be good. So in the children, they are pure hearted, so good, right? But if it is occurring, right, 2 to 10 years, it is going to be bad, right? So good and bad. Now what about the sex? I told you girls and boys. So females good, boys are bad, right? So please remember, boys mate is going to be bad, obviously, है ना? And they can give you the race, but usually race are not given in the FMG, so I didn't mention over here. White population mein it is going to be good prognosis, and this is going to be bad in them. Okay, so bad, it is going to be in the this thing. All right. Chalo, genetics में hyperdiploidy or hypodiploidy. Now, what do you mean by diploidy? Chromosome, number of chromosome. Usually, you do have 23 pairs of chromosome, right? Or 46 chromosome. So, if it is 47, it is hyperdiploidy, right? And if it is 45, it is hypodiploidy. So, if it is hyperdiploidy, it is going to be good, and if it is hypodiploidy, it is going to be bad, right? कम है तो problem है, because the proteins won't form. ज़्यादा है तो कोई बात नहीं, वो sometimes it get the dominant also, right? B cell, T cell, है ना? B cells are usually good. अब bad पे B मत जाना, right? So B cells, if it is B cell 1, it is good, and T cell is traumatic, it is bad, right? So T cell leukemia is there, then it is going to be bad. And why? Because T, remember, B remains in the blood, leukemia is there, and it remains in the blood. It won't cross the blood, right? But T means it goes in the tissues and it start to involve. I think it won't be visible. I'm writing over here T for tissues, right? So it involves the tissues. That means what involvement will be there? CNS, testis and mediastinal environment will be there, right? So we used to remember like middle CT, right? That means the mid CT, that is the mediastinal, C for CNS and T for testis. So these involvement, if it is given, it is going to be bad, okay? If it is in the blood, it is not involving the tissue, that means metastasis is not there. But as soon as it involves the CNS, definitely the prognosis is going to be poor. Involvement, it is not there, it is there in the bad one, okay? B for behtar, wow, nice. So B for better also, right? So blood, but better, right? We are Indians, right? Chalo, let's move on to the types. We have two types of lymphoblasts are there. T types हो सकते हैं या B types, है ना? B is going to be better and T is going to be bad, right? So it is going to be traumatic. So this is B and T. So B cell, I told you, better prognosis is there. It is more common. Maximum age is going to be 3 years, and this is going to be happening in the puberty, है ना? दिमाग कब खराब होता है लड़कों का? जब puberty आती है, right? So T cell is going to be bad, and the puberty is going to be the most common age to happen that. It is more common, thankfully. So see, whatever is more common, this is going to be good, okay? And whatever is less common, least common, that is going to be bad. Definitely it is going to be bad ones, okay? So that is there, okay, right? So bone marrow is going to be positive. Why? Because I told you B goes in the blood, right? And T goes in the, it not only remains, it is a leukemia, so it will be in the blood, but it involves the tissue also. So it is going to be bad, right? So if it goes in the thymus and start proliferating there, it lodges, the cells lodges there and it start proliferating, definitely it is going to cause the thymoma. Okay, and CD markers, we know that you guys only told me T for tiny and B for bigger ones, right? So numbers are going to be accordingly 1, 2, 5, 7 and the 10, 19 and 20. Please remember this 19 at least. Okay, so that is going to be pan B marker. This is going to be better prognosis, poor prognosis, no fun, है ना? It is useful, yes. Everything is useful. Knowledge never goes waste. Okay. चलो, let's move on to the next thing, that is B cell ALL. B cell ALL में PAX5 mutation भी होता है. You just remember that because again we learn the PAX5, but काला antigen वगैरह हमने किस में पढ़ा था? Yes, we did that in the T वाले में, but over here it is going to be B cell ALL. It is associated with the PAX5 mutation. Again, Philadelphia chromosome is also there. We are learning over here ALL. So please remember, in two things we do have Philadelphia chromosome. किस में देखा था हमने? ALL में we are looking at this right now, and we also saw this in the CML. What is the difference between these two? We'll see that. Please remember, Philadelphia is positive in both ALL also and CML also. But the activity of the tyrosine kinase is going to be stronger in the ALL. As I told you, acute में it is going to be the worst. Stronger tyrosine kinase activity means it is going to proliferate much more. That means at higher rate it is going to proliferate. On the other hand, if you talk about CML, it is a chronic condition. Chronic condition mein this is almost around 210 kilodalton, right? This KDA, what is it? It's a weight, molecular weight, right? No need to remember, I just wrote it like that. So it is the kilodalton. Bigger the molecule, lesser will be the activity, है ना? जैसे obese person में activity less होती है, so please remember like that ways. So chronic में the activity is going to be weaker, right? So weaker tyrosine kinase activity is going to be there, right? So please remember that ALL में and CML में, in both the things, the Philadelphia chromosome is going to be positive. Though they won't be giving you confusing statement, definitely, but हाँ, दोनों में पॉजिटिव आता है if they have given which of the following have the Philadelphia chromosome positive and they have given CML, ALL, both of the none of the above. Go for both of the above and do not in a hurry, do not mark any one of these, right? Usually we remember for the CML, but we forget that in the ALL also it is going to be present. So please remember, in both of them the Philadelphia is positive. So if both of them option is there, we are going to mark that one. Comes the FLAP classification, right? We have learned the FAP classification earlier also, but this is for the ALL. Thankfully, it does not contain the 8 different types. It just contains 3 different types. Lymphocytic है तो L1, L2, L3 बस 3 पढ़ने हैं हमने, right? The L1 is going to be most common. If it is most common, है ना? It is not an abusive word. It is the most common, right? So most common type. I told you, If it is most common, thankfully by nature bolo ya fir if the disease is more common, the research is happening, whatever research is happening, that is much more common, and we can treat it, we can diagnose and we can treat it earlier. So it is also kind of a better prognosis, right? So it is having a better prognosis. Just remember that. Inconspicuous matlab dikhai nahi deta hai, proper nuclei are not seen and the cytoplasm is going to be scanty. That is there in the lymphoblast, right? Comes the L2. L2 में क्या होता है? Because larger cells are going to be there and pleomorphic cells are going to be there. Nobody is going to ask you the question on L2, but L3, yes, it is least common, and least common है तो it is associated with Burkitt's lymphoma. Burkitt lymphoma, if they wanted to ask you what scenario they are going to give you, just tell me what is the most common scenario. I have come across so many questions about the Burkitt's lymphoma. It is much more common. Specifically, they will give you one specific scenario. ऐसे कुछ jaw निकला होगा, specific ethnicity होगी. So please tell me. Yes, if you know that, please tell me. Okay. So, and then comes the mature B cells. We can see the mature B cells. It is going to be there in the L3. Right. So symptoms are similar like AML. क्या पढ़ा था AML में हमने? That the RBCs will be less, the platelets will be less. RBC less है तो anemia होगा, fatigue, pallor, easy fatigability और dyspnea के साथ patient will come. In the thrombocytopenia, bleeding disorders will be there, easy bruisability will be there, and with that they can give you the case of purpura or petechias. Okay, in that cases also this is going to take place. These are similar, so we are not going to revise them again and again. There is lymphadenopathy. You can see the lymph nodes over here, cervical lymph node. If the case is in India, first of all, we won't directly go to the AML. We will think of TB first, okay, because we are living in the India. Then comes, it is more common. If it is leukemic tumorous condition is given, then definitely you are going to go to the ALL and AML. Specifically, if they want to tell you towards this ALL, then they will be giving you TDT and PAS positive. We know that the PAS, I told you, PAS, P आ रहा है या phosphatase आ रहा है. So lymphoblast होगा, not the myeloblast. What were the stain for the myeloblast? Tell me, myeloblast के क्या stains थे? M for M, I told you, myeloblast के क्या stains थे बच्चों? And PAS, periodic acid shift, we saw that. है ना? Now what is this TDT? नाम याद रखना है, रख सकते हो, नहीं तो कोई बात नहीं, है ना? They are going to give you the name, that is, this is terminal, है ना? Patient वैसे भी मरने वाला है तो terminal stage पे है, and this last T is for transferase. What is this D? This is deoxynucleotidal or nucleotidyl transferase. Yes, absolutely wonderful. Aditya, Gerald, I don't know what that note, musical note है ना, Twinkle, Divya, all of you are right, है ना, Divya. So MPO is the one, है ना, and for that PAS and acid phosphatase, especially for the T wala cell, right? So terminal deoxynucleotide, this transferase is seen in the ALL. So it is going to be positive. Now, see over here, if you see such kind of lymphoblast or lymphocytes in the cell, you can guess this. So can you see the cells over here? How should I identify that these are the lymphoblasts? See, it seems like the nucleus is covering almost all, 80 to 90%, more than 90%, 90 to 95% of the cytoplasm. If almost 90 to 95% or even 80 to 90% of the nucleus, the cytoplasm is covered with the nucleus, it cannot be any other than the lymphoblast. So बहुत सारे lymphocytes, lymphoblasts ऐसे दिखेंगे आपको, then definitely it is going to be the ALL, right? So it is going to be ALL. So you can see blast में हल्का सा you can see the this cytoplasm over there, but the main difference is in the size. So in the background, you can see these are the RBCs, around 1.5 to 2 times the lymphocyte is going to be there, but lymphoblast is much larger, 3 times larger than the RBC. Usually we say that, okay? So आप बहुत सारे ऐसे सेल देख रहे हैं, 3 times larger, nucleus is covering all of the cytoplasm, almost all of the cytoplasm, then ALL. mark the error and you will be good to go. Okay, चलो जी आते हैं क्लिनिकल फीचर्स में. व्हाट विल बी द क्लिनिकल फीचर? लिम्फोसिटिक ल्यूकीमिया है. सो क्या क्या देखने मिलेगा? हमें मिलेगा एनलार्जमेंट ऑफ सुपरफिशियल लिम्फ नोड. आई शोड यू दैट डायग्राम आल्सो. तो लिम्फोसिटिक है, ऑब्वियसली लिम्फ नोड्स विल बी enlarged and usually symmetrical and discrete, non-tender. If you touch them and if you press them, there will be no pain. So after, what is the difference between pain and tenderness? If you touch that and then the patient has the pain, that is known as tenderness. But they are non-tender. That means the patient won't feel any pain. And mild leukocytosis is going to be there. Now, tell me, there is specific type of cell. I am making the cell while, let's say I took the blood sample, and this is one of the slide. I'm making the peripheral smear, right? I'm making the smear with the another slide, right? So while making the smear, so ऐसे जाऊंगी मैं, यहाँ पे blood drop होगा, I'm taking the blood drop and I'm going to make a smear. What happens that some of the lymphocytes, their cytoplasm breaks away. Okay, so they are going to form some type of cell. Can you tell me what type of cell it is? At least 3 hours you should be able to sit. Ashutosh? चलो, at least 3 hours exam में भी बैठना है ना? So, important है. So, you are going to see smudge cells. Yes, Roy, absolutely right. You are going to see smudge cells or basket cell. Why these smudge cells are there? Because as the lymphocytes are forming, lymphoblasts, not the cytes, the lymphoblasts are forming, they don't have vimentin in their cytoskeleton. You must have learned in the physiology itself, cytoskeleton. Skeleton का क्या function होता है? Support. एंड हम बात कर रहे हैं कौन से स्केलेटन की? साइटोस्केलेटन, सेल का स्केलेटन, राइट? सो सेल स्केलेटन इज नॉट देयर, सम पार्ट इज नॉट देयर, सो डेफिनेटली इट इज गोइंग टू बी deficient, so it is going to form the smudge cell. But is it there in the bone marrow, or normally in the these smudge cells are there in the blood, or we formed it? We formed it, right? So it is an artifact and not the problem in the blood per se. So it is happening while making or while preparing the slide. So you can see that there is no particular border, you can see, है ना? So it is looking like a basket cell or smudge cell, right? So it is artifact. It is an artifact, and this is due to vimentin, which is not there. Usually while making the smear, we press the blood drop, है ना? During that pressure, this vimentin is not there. That's why the cell borders, the plasma membrane breaks away, and that's why the whole cytoplasm spread onto the slide, and that is how the smudge cells or basket cells are formed, which is already written over here, है ना? चलो आगे बढ़ते हैं. बोन मैरो एग्जामिनेशन में व्हाट यू आर गोइंग टू सी? ऑब्वियसली लिम्फोब्लास्टिक ल्यूकीमिया है तो लिम्फोसाइट काउंट बढ़ जाएगा. Myeloid and erythroid precursors are going to be less, and markers are going to be CD19 and 20. With that, 5 and 23 is also present. Please mark this point. I guess that is not there in the PDF. So 5 and 23 is there, but important thing is CD19 and 20 is going to be positive, right? चलो जी आगे बढ़ते हैं. What will be the treatment? क्या देख सकते हो ट्रीटमेंट में? एक्यूट में बच्चे आ रहे हैं ना, so you do not know, so you start with the symptomatic treatment, right? So symptomatic treatment, anemia हो रहा है, hemorrhage हो रहा है, whatever it is going to be there. Why hemorrhage is there? Again, anemia, why it is there? Because myeloid lineages are less, RBCs are less, platelets are less, because lymphocytes are now taking all the energy and they are growing at a abnormal high pace, right? So that is going to be there. Chemotherapy you can give, that is Kristin-Pal. Now what is Kristin-Pal? This is not any drugs, this is a mnemonic, right? What the mnemonic states as Vincristine, the P for prednisolone, obviously steroid hai, dena padega, right? And then comes the anthracycline, again daunorubicin, adriamycin, all these types, and L-asparagines. Okay, so please make a note of it. Yes, chemo start karna padega hame, that is Kristin-Pal. ओके. इंट्राक्रेनियल मेनिंजियल ALL है तो क्या करोगे आप? इंट्राथीकल, दैट मीन्स सी इफ यू गिव एनी ब्लड दिस थिंग chemotherapy in the blood, definitely it is going to have hard time to cross the blood brain barrier, so it won't be reaching to the blood brain barrier. there is a special type of fluid surrounding the brain, and that is none other than CSF. So what you can give via the lumbar area, you can directly give the drugs into the CSF. That is known as intrathecal methotrexate, right? So that thing is known as intrathecal. Directly you are going to give in the CSF so that it can reach up to the brain, you know, if only the meningeal involvement is there. Ultimately, treatment of choice is going to be bone marrow transplant. There is no another replacement for the bone marrow transplant. Please remember, bone marrow transplant is ultimately important. चलो जी, then we'll come to the CLL. CLL क्या है? Chronic lymphocytic leukemia, है ना? So chronic में क्या होगा? There is not much information about chronic, but yes, important. If it enters into the lymph node, it is also called as small lymphocytic lymphoma. Okay, it is not leukemia now. I told you solid organs में enter करते ही we will call it as lymphoma and not leukemia. But it was the leukemia first which turned into the lymphoma. So definitely it will be called as small lymphocytic lymphoma. इसमें कौन से सेल दिखेंगे आपको? You are going to see mature B cells around 95%, right? Definitely it is going to involve, because we are learning about leukemia, I told you EMEA means blood. So it is going to involve bone marrow, वहाँ से production हो रहा है, and then comes the blood, right? Then it comes into the blood. Age is going to be 50 to 60 years, है ना? Male and female में. Obviously in the male it is going to be higher. All the lymphocytic, they are bad for the males, right? Most common leukemia in the elderly, I told you, if the person is elderly, chronic ones are much more common as compared to the acute one. Acute never seen in the elderly. Elderly mein chronic are much more common, but the most common in the elderly is going to be this one, that is the chronic lymphocytic leukemia. Okay, mature bhi ho gaye hai na, so elderly mein this is going to be much more common. If we do have CLL and SLL, there is one transformation. If it converts into the DLBCL, that is diffuse large cell B lymphoma, then this is going to be much more severe, right? Because DLBCL is going to be much more aggressive as compared to CLL and any other type of leukemias, right? There is one name for it, right? This is known as Richter's transformation. Please highlight this point that yes, the CLL एक तो elderly में हो रहा है, उनकी immunity वैसी down रहती है, right? And if that get converts, CLL तो ठीक था, we can manage that easily, but if that converts into the diffused large B cell lymphoma, then it is going to be much more aggressive, which is difficult to treat, and the patient do not live longer. And this transformation is known as Richter's transformation. है ना? Rich होगा तो अच्छा है because the future generation is going to enjoy, right? But not good for that person, right? So DLBCL. Okay, chalo. Let's move on to the genetics. Genetics is important. There are many four things which are important mainly. Yes, there are other notch transformation and notch cytogenetics is also there. First of all, we'll see up to this. Please remember 11, 12, 13, 17. Everything is QQQ. 17 is P, right? Only 17 is P. Now, out of this 11, 12, 13 and 17, 11Q, 12Q, 13Q and 17P. All of them are deletion. Only 12Q is 12 trisomy. So please remember 12 is trisomy. Okay. So what happens in the other things? If 11Q is involved, that means 11Q will be deleted. So deletion occurs in all of them. Deletion, deletion, deletion. So that chromosome part will be deleted. That means the long arm of these 11, 12, 13 and the short arm of this 17, that is deletion. All of them will be deleted. Only the trisomy will be of 12. Okay, so 12 trisomy. 13 is going to be most common over here. Out of all these genetic mutation, which will be most common? The most common one will be the 13Q, right? 17 deletion short arm, right? Yes, Dr. Fett? right? So this is going to be the genetic. See, that happens. There is no per se reason, है ना, कौन सा gene कब उसको बिगड़ने का मन हो जाए, right? We do not know, है ना? So we think as someone is good, but near change hoti rehti hai, right? So there is no particular per se why this happened. There is no concept in this. So you have to remember the cytogenetics. You can make any mnemonic if you want. They say that 12 sounds like trisomy, so you can remember that also. Okay. Now, there is notch transformation. Notch mein T aa raha hai. So, if notch transformation or notch defect is there, please remember it is going to form the T cell leukemia and not the B cell one. So, it is gain function mutation. That means it is going to work much more. So, notch forms the T cell much more. So, definitely it is chronic lymphocytic and not blastic. So, lymphocytes are going to be much more. Which lymphocyte? T wale. Okay. And it is not association with radiation. The history won't tell you that radiation is available. Either chemotherapy or some other genetic mutation will be there, but it is not at all associated with the radiation. Now, abnormal B cells, they cause autoimmune disease, and the most common autoimmune disease will be of most common cells. Please remember, I'm not talking about most common WBC, I'm talking about most common cell. These are RBCs. So the antibodies are formed against them, and if the antibodies are formed, our own body is forming antibody against our own cell, that is autoimmune disease, and this type of autoimmune disease is going to form the antibodies against the RBC, which will break down the RBC, and if the RBCs break down, we call it as hemolysis, isn't it? So this is known as the autoimmune hemolytic anemia. So I'm writing the name over here. The most common type of autoimmune disease which occurs, it is going to be autoimmune hemolytic anemia. Right? Tomorrow we are going to talk about it in detail, but just for now remember this. Okay? If it is combined, you see that CLL is there. Cytogenetics से आपको पता चल गया that CLL is there, and you see AIHA with that. This is known as Evans syndrome. Never asked in FMG exam. If you want to remember, you can. Otherwise, you can skip this. Evans syndrome can be seen, which is related to the CLL. With that, autoimmune disease will be there. Which cell this is, bacho? Which cell is this? It's looking like something is there and there is a handle, right? So these are looking like, what is this? Which type of cell are they? Please answer me in the comment. है ना? Yes. Thank you, Roy. Thank you. That is our job, isn't it? To make it easy rather than just reading the PPTs. Yes, all of you are right. Preksha, Dr. Fed, Jyoti, Shabaz, Payal, Gerald, Osama, right? Twinkle, right? Yes. So these are smudge cell. Again, I have next slide for it. That is smudge cell. Clinical features में asymptomatic होता है. That is dangerous because elderly में वैसे ही बहुत सारे symptoms होते हैं. So sometimes we miss the patient of CLL, है ना? जब तक वो miss नहीं हो जाता दुनिया से ही, right? So asymptomatic. Why? The one of the reason is it is asymptomatic in the starting phase because lymphocytes आ रहे हैं, lymphoblasts नहीं आ रहे हैं. So sometimes we misinterpret that or we miss that, right? But yes, lymphadenopathy is going to be present. Then comes the HPE. In that, smudge cell, parachute cells or basket cells can be there. It looks like a parachute, hai na? Person is there and this is a parachute with which it is holding, right? So parachute cells or smudge cells, and in the IOC, I think it is not there in the PDF. Please make sure that you are writing side by side. Investigation of choice is going to be flow cytometry. In that, we are going to get the CD markers 5 and 23 positive. 5 and 23 positive is going to be there. चलो आगे बढ़ते हैं. Treatment. What treatment you will prefer? Elderly person is there. You do not know whether he is having CLL or not because it is asymptomatic. Usually we go with the palliative treatment or symptomatic treatment, but we avoid doing the bone marrow transplant. Please make a note of it. They are going to ask you what you will try to do in this. please make a note that it is happening in the elderly patient, है ना? First of all, it will be asymptomatic. Then the patient comes to you, you try to diagnose something. So usually we avoid doing the bone marrow transplant. There is one drug though, right? There is one drug. Can you tell me whose pharma is good? There's one drug. I want the name of the drug from you guys. Yes, conservative, so we are going to start, but we are avoiding the bone marrow transplant. So specific drug we have to give. Fludarabine. So make a note of it that the drug of choice, if they ask about the CLL, so this is going to be fludarabine. Okay. Yes. Shabazz, you told me that. So fludarabine is going to be there. Dr. Patel, yes, you're right. Osama, Faraz. So fludarabine is going to be there. Let's come to the lymphomas. Now we have done the leukemias, है ना? हमने ALL कर लिया, mid में हमने myeloproliferative disorders भी कर लिए. What I want you to do is, after the class, just sit for 10 minutes. 10 minutes sufficient for that, है ना? Around 90 pages are there. So just go through it. Okay, just quickly go through it. Whatever I told that this is most important or star mark this, just go through it and try to solve at least 20 question on these topics. Okay, leukemia se 20 questions solve karne ki koshish karo. Okay, coming to the lymphoma, we all know two types of lymphoma: Hodgkin, non-Hodgkin, right? Hodgkin mein, I told you first of all which cells will be seen. If the examiner is marking you the Reed-Sternberg cell, ये तो मिस ही नहीं करना है ना? It is look like owl shape, right? It used to look very cute to me. I don't know why, but owl looks cute to me, है ना? So Reed-Sternberg cell, never miss this, है ना? Hodgkin अगर है Reed-Sternberg, then it cannot be any other than the Hodgkin. So please remember, owl आया तो Hodgkin mark करना ही है, right? So more symptoms will be there. अर्ली डायग्नोसिस किया तो अर्ली ट्रीटमेंट भी स्टार्ट कर पाएंगे और प्रोग्नोसिस अच्छा हो जाएगा, राइट? सो वी कैन स्टार्ट द ट्रीटमेंट अर्ली, सो गुड प्रोग्नोसिस विल बी देयर. एंड वी नेवर एवर फॉरगेट दिस, Reed-Sternberg. If I wake you up from the sleep and if I ask you ki Reed-Sternberg cell is there, you should tell me that it is Hodgkin lymphoma. Okay, so in your dreams also you should tell that Reed-Sternberg is there. That means RS cells are there. It is none other than the Hodgkin lymphoma. Okay, there is one virus also which looks, or in which we can see owl eye appearance in the other things. What is that? Can you tell me? One virus is also there. Yeah, this is not per se. Yes. Oh, okay. Oh, it is written over here. No need to tell. That is cytomegalo. Okay. I didn't see that. Cytomegalovirus is there and lymph node is continuous. What do you mean by continuous? Suppose there are 3-4 lymph nodes like this. Okay. And the lymphoma start in this lymph node. So it will go in the adjacent lymph node first. Yes. You guys are right. It was written there. Divya, yeah, Patel, Arefa, you all are right. It was written. I didn't see that. Right. So, then there is next. It won't happen that it is directly jump from 1 to 4th or 5th lymph node. That doesn't happen in the Hodgkin wala. But in the non-Hodgkin, this will be seen that the lymph node involvement is non-contiguous, right? So that is going to be there. And extranodal, rarely it involves extranodal. So that is also leading us towards the what thing? एक्स्ट्रानोडल शायद ही कभी वो नोड छोड़ के बाहर जाता है. सो दैट इज अ गुड प्रोग्नोसिस, isn't it? So it is not leaving the node, so it is good for us. If you remove those nodes, the lymphoma will be gone. So good prognosis, again a good prognosis. But non-Hodgkin, so non-Hodgkin may RS cell won't be seen, right? RS cells are absent, those cute cells are absent, so it is going to be bad for us, है ना? So less symptoms, late diagnosis. So definitely late diagnosis is there. The condition is much more worsened now, and that's why the patient will be having bad prognosis, right? Non-contiguous, opposite to that of the Hodgkin. If you know the symptoms of Hodgkin or you know the points of Hodgkin, you can easily exclude the non-Hodgkin ones. Extranodal are usually involved, right? So node se bahar chala ja raha hai, so definitely it is going to be bad prognosis again. And B cell and T cell, both the types can be there. Okay, so can you guess what is it? Everybody will know this now. Tell me, what is this cell? if this kind of, okay, anything else in this, right? Okay. So can you see these cells? What are these cells, guys? What are these cells? You cannot miss these cells. What are these cells? Yes, RS cell. And that means, yes, this is going to be the Hodgkin's lymphoma, right? So Reed-Sternberg, normal lymphocyte. Now, I added this slide deliberately. Why? Because, in 2018 or 19, I saw this, that they have so much good cells, right? But in the NEET PG, they particularly give this diagram. It looks as if the peripheral smear is there and they pasted this cytomegalo, Reed-Sternberg cell over here. Isn't it look so fake, and we people cannot do the proper hard work, they didn't get the proper slide, must be there, and copyright issues must be there. So that's why they exactly kept this thing, that is normal lymphocyte and Reed-Sternberg, not in the FMG, but the NEET PG exam, right? Anyways, chalo. बहुत bitching हो गई NB peoples की. Let's move on to the Hodgkin. Most common node involved. Same as the TB. TB में भी cervical usually most commonly involved या most commonly हमें मिलती है. Right, so that is there. Most commonly lymph node involved in the Hodgkin is also cervical lymph node. You cannot forget the cell, that is the Reed-Sternberg cell, and we know it is a cute owl-like appearance. Then comes the particular markers, that is CD15 and CD30 positive. Please make a note of it that this is the classical. When we say classical Hodgkin, that means it is typical for that Hodgkin to happen. There are types of Hodgkins where this 1530, or there are types of other lymphomas which we are going to see later on, the non-Hodgkin per se, which are non-classical. So in that, maybe 15 is positive, 30 is negative, 30 is not positive, especially there are popcorn cells and other type of cells are there in which both of them will not be positive. But if it is a classical Hodgkin, then definitely you are going to get the 1530 positive. You should be happy that it is 1530 positive if the lymphoma comes. Why? Because it is having better prognosis or good prognosis, right? Yes, it is written that it is classical form, owl eye appearance. I don't know, the video is I cannot see the video over here. Please let me know if the audio video is proper. Am I visible, guys? Am I visible? चल रहा है? नहीं 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 चल रहा है. I cannot see यहाँ पे. क्लास नहीं खत्म हुई. Okay, I'm not getting your replies, and some problem is there maybe in the net, है ना? नहीं हुआ, iPad में नहीं चल रहा है, इसमें नहीं चल रहा है. चल रहा है ना, क्लास चल रही है, राइट? चलो, classical form is 15:30, so there is some technical error. Till that happens, I hope it is visible. Chalo, let's move on to the next thing, that is it is associated with one virus, that is Epstein-Barr virus. Okay, so Epstein-Barr virus usually Hodgkin's में हमें मिल जाता है, right? So if you, how we used to remember that this is a cell, this is the owl eye appearance, है ना? And if you do that, you turn that sound, that is going to be B, right? So Epstein-Barr virus. So Epstein-Barr virus, Hodgkin lymphoma. Please remember, Hodgkin में Epstein-Barr virus का association is much more common. So they can give you this scenario also. Let's move on further. Types of Hodgkin lymphoma. So there are types. I told you there is a classical form, but there are other types also, है ना, which will be non-classical, है ना? So nodular sclerosis, mixed cellularity, lymphocytic rich, lymphocytic depleted, and lymphocytic predominant, it is going to be there, right? So rich people are there, but India में सबसे common कौन होता है? India में most common it is going to be mixed population, है ना? So rich भी है, poor भी है, middle class भी है, right? So all good. Okay, चलो. I couldn't see your this thing also, comments also, because it was not there. All right. So बाहर जाने के बाद फाइन. So lymphocytic rich, lymphocytic depleted, most common India में पूछा, so definitely mixed population is there. So that's how, please remember, it is going to be mixed cellularity. Okay, and classical format अगर पूछा तो definitely it is 15 to 30 positive, right? चलो, let's see this diagram over this chart over here. You just have to remember Hodgkin में non-classical में you have to remember just this chart. Even if you take any book of MCQ, I promise you that 99% of the question will be solved of the NEET PG also with this chart. You have to mug up this chart, important, very important. Okay, so 5 types we saw: nodular sclerosis, mixed cellularity, lymphocytic rich, depleted. That means lymphocytic poor also. Either they can give lymphocytic poor or lymphocytic depleted also. ठीक है, मिलिंद की आंख अभी खुली है, राइट? सो mediastinal environment हो गया भाई. Mediastinal environment, that means we are going to say lacunar cell. I'll show you something, है ना, which is very very interesting. You can see as if something is missing from this cell, isn't it? It is a very large cell, and if they show you a particular this type of cell, yeah, you can see, appreciate over here, you see something is missing from the cell, the cytoplasm, or don't know, the granules, and you look, if it seems like something is missing in between, right? Like something is missing from our brain also, that happens with us, isn't it? So similarly, lymphocytes also look like that. So it is a proper lacunar cells, है ना? There are lacunas in our brain also. Sometimes it gets stuck or it get hang also. So similar cells are going to see in the नोडुलर स्क्लेरोसिस. स्क्लेरोसिस हो जाता है तो उस टाइम पे हमें वहां पे कुछ भी नहीं दिखता है, राइट? सो mediastinal environment is going to be there, and nodular sclerosis, it is most common worldwide. It is most common worldwide. Most common India में कौन सा बताया था? Mixed population is there, so please remember mixed. Yeah, it is going to be mixed population. So mixed non-classical type of Hodgkin's, that is mixed cellularity, is most common in Hodgkin's in the India per se. Classical RS cell is seen, है ना, but हम cute लोग हैं, right? Indians are cute usually, right? So please remember RS cell will be positive. If RS is positive, definitely 1530 both will be positive, है ना? 1530 यहाँ पे भी positive है, यहाँ पे भी positive है, okay? Not in other things, and that's why I haven't mentioned over here. This is having bimodal peak. What does that mean? That either it is seen that it is most commonly seen in the 5 to 15 years ka age, right? Or it is seen in the 40, after 40. So there is no mixed cellularity Hodgkin lymphoma seen in between 15 to 40 years of age. Okay, either early in the childhood or late in the elderly ages, we can see this is known as bimodal peak. Okay, that is seen. Lymphocytic rich, it is classical RS, again 1530 will be positive over here. Okay, and lymphocytic predominant में, please remember CD20 is positive. With that, if you want to remember, CD45 may be positive, may not be positive, है ना? So usually they won't be giving it to the FMJ exam per se, I don't think so. But हाँ, NEET PG में sometimes it is asked 45 positive हो सकता है, right? So lymphocytic predominant में होता है, depleted में, poor में, poor cells are there. How they look? They look very thin and मरेले से लगता है, right? So mummified, है ना? It like a mummy. So mummified RS will be there. It won't be cute anymore. So it will be mummified RS. Why? Because they are lymphocytic depleted. They are poor. They are not getting the nourishment, right? So they are kind of dying. So mummified RS. Please remember that. Least common है और ये भी worst है. Mummies are always worst, right? So I'm not talking about the घर की mummy, right? So the mummies I'm talking about movie वाला mummy, है ना? So घर जाना है सबको ultimately कभी ना कभी. तो least common and worst, that is associated with HIV. Obviously, so it is going to be the worst. So HIV के साथ association है. Obviously, everything is worst in this, right? चलो, tell me what type of cell do you see over here? ये कौन सा cell है बच्चों? This last 15, 20, 20, 25 minutes and I'll leave you guys. Lymphocytic predominant में BCL2 is positive and this is going to have a good prognosis. Please remember that also, okay? Everything is written in that chart. You have to remember that chart, okay? Yes, you guys are right, absolutely right. What you can see is, yes, popcorn cell over here, है ना? So this is nothing but the popcorn cell. So popcorn cell, है ना? So there is no particular cell shape, size, है ना? The nucleus or the cell even looks very different, है ना? We will not be able to identify which type of cell it is, or multiple cells coming together. We won't be able to appreciate. So this is known as the popcorn cell, right? And can you see something over here? Can you identify this cell? What is this cell over here? What is this cell? हाँ जी बताओ. There is one cell here and one cell here. No. If you can just make sure that you see the proper smear, you can see many cells over here, है ना? So यहाँ पे भी है, बहुत अच्छा सा cell है, right? So let's say this is cell A and these type of cell are cell B. So tell me what type of cell these are. Yes, Roy, you are right. Osama, yes, I got the answer. So these type of cells, they are mummified RS, है ना? As if they are dying. So mummified. And what are these? These are RS cell. If you are not sure, just see the smear properly. You are going to get the RS cell. थोड़ा सा definitive नहीं होगा, but you can see the RS cell also in the background, है ना? So you can see this is the RS cell. ये दो न्यूक्लियाई हैं. This is another two nuclei. Cute owl-eye appearance, right? So RS cell is also there. Okay, so they will be marking which cells they want to, you know, make you to get into the notice. So that is going to be there. So mummified RS. Okay, so सारे cells यहाँ पे दिखाए हुए हैं. कैसे कैसे हैं? So RS cell, this is Reed-Sternberg cell, and this is lacunar. Something is missing from here, है ना? As if our brain is there, ना? And this is the popcorn cell, mummified RS. Right? Everything is written. This slide is also there in your PDF, so you can see it patiently while you are enjoying dinner after finishing the class, right? Moving on to the non-Hodgkin lymphoma. Before going to the non-Hodgkin lymphoma, you should know from where they are originating. Again, non-Hodgkin lymphoma, baby, there are two types. As we divided the ALL type, B cell, T cell, non-Hodgkin may be same division, B cell, T cell, and then not only that, but they are going to have subtypes, but you should know their origin because it is asked, right? हमें कोई फन नहीं आ रहा इसको पढ़ाने में और आपको पढ़ने में, right? But you should know the origin of this. Suppose there is a lymph node, there is going to be central part, then there is going to be the mantle zone. There is a zone which is known as mantle zone, and then there is a marginal zone. The end part or the margins of the lymph node, that is known as marginal zone. So this is showing the zones of the lymph node per se, right? So this is the germinal center. Obviously germinal center ही बोला है, so obviously it is germinal center, so it is going to be in the center. Then comes the mantle zone, and then comes the marginal zone. Only two things you have to read carefully: mantle zone and marginal zone. The name itself suggests there tumors arising from them. Mantle zone से निकलेगा mantle zone tumor or mantle zone lymphoma. Again, this is going to be B type lymphoma. Marginal से कौन सा निकलेगा? Again, same thing. How difficult it is, है ना? Marginal zone lymphoma. Very difficult कि mantle zone से mantle निकल रहा है marginal से. Very easy, right? So mantle zone से mantle and marginal से marginal. Okay, I'm going to show you a slide in which there will be classification of the B cell and T cell. There are many subtypes. There is DLBCL, which we have mentioned in the Richter's transformation. अगर CLL convert हो गया DLBCL में, that DLBCL, right? And there are other types like follicular type and Burkitt's lymphoma even. That comes from the germinal. Remaining सारे आते हैं germinal से. ये दोनों याद रखना. There is one leukemia is also going to come, which is hairy cell leukemia. It is in the blood, so we won't be just correlated to the lymph nodes, है ना? So that won't come in the any zone. It is not mentioned per se. So please remember these things over here. Let's move on. So thank you, G. Thank you. B cell and T cell. So I told you that B cell is going to have multiple things, but you just have to remember, because see, again, you don't have to write everything. सब्जेक्टिव एग्जाम नहीं है, आपको नहीं लिखना है एग्जाम में जाके, यू जस्ट हैव टू मार्क, है ना. सो ओरिजिन अगर जानना है तो ये सारे के सारे आएंगे बी सेल में. एंड देयर आर टी सेल्स. टी सेल्स आर वेरी इजी, वेरी वेरी इजी. माइकोसिस फंगोइडिस, इट इज अ क्यूटेनियस ट्यूमर. यहाँ पे ऐसे स्किन का कुछ लीजन दे के आपको, या तो हिस्टोलॉजी स्लाइड दी है और स्किन का कुछ बताया हुआ है, मेंशन द स्किन, एंड इट इज गोइंग टू बी टी सेल नॉन हॉजकिंस. और ALCL लिखा हुआ है, देन इट इज गोइंग टू बी टी सेल. बट ALCL क्या है? एनाप्लास्टिक. इट इज एनाप्लास्टिक. We'll talk about it later. Just let's discuss the B cell wale lymphomas. I told you mantle zone se mantle cell lymphoma and marginal zone se marginal zone lymphoma will be there, है ना. This is leukemia. Yes, it is leukemia because it is involving blood, but it starts from the lymph node itself. So it is kind of a lymphoma also, right? And comes the follicular cells, Burkitt's and DLBCL, that is diffuse large B cell lymphoma. They all come from the germinal center. तो आपको याद क्या रखना है? मैंटल जोन से मैंटल निकलता है, मार्जिनल से मार्जिनल, बाकी सारे जर्मिनल सेंटर, राइट. लेट्स मूव ऑन टू द फॉलिकुलर लिम्फोमा. यहाँ पे एक जीन इंपॉर्टेंट है दैट यू हैव टू रिमेंबर. अगेन बी सेल में ना 14 बहुत आएगा. व्हाट इज 14? दैट इज 14. 14 will come everywhere, है ना. यहाँ पे 4 है, so please remember 14 will come many places everywhere, and you just have to remember the another number. So please remember यहाँ पे होता है translocation T 14:18. So gene involved over here is 14:18. Okay, that is the gene involved. I don't know whether I wrote there or not, but BCL2 mutation, yes, it is there. BCL2 mutation is going to be there. It is anti-apoptotic. Anti-apoptotic अगर बढ़ गया, so apoptosis नहीं होगा. There will be no apoptosis. That means lymphoma will be formed, isn't it? So that is very very easy. So please remember with the follicular, please remember 14 and 18. So follicles, so I used to write like that, follicular lymphoma, है ना. So please remember follicular lymphoma is going to be 14 and 18 together, and BCL2 positive. BCL2 will be increased. BCL2 is anti-apoptotic, so lymphoma will be formed. Apoptosis won't take place. Indolent cause, that means it is going to be having good prognosis, right? Why it is called as follicular lymphoma? Can you guess? Because it forms follicle, right? So it forms follicle, and that's why it is known as follicular lymphoma, right? HPA में आपको क्या दिखेगा? There are going to be cleaved cell or buttock cells. Okay, if someone sends you something like this on the WhatsApp, Telegram, please block that number. Why? Because this is not the shape of the heart. This is the shape of the buttock when you kneel down, है ना. So please do not make such heart diagrams, है ना. So heart कैसा बनाना है आपने? Atria बनाने हैं, ventricle बनाने हैं, then you are going to make aorta, pulmonary arteries, and so on and so forth, right? Easy diagram will be like this, है ना. So ये भेजो, not the other one, right? So cleaved nucleus, let's see how it looks like. Cleaved nucleus or buttock cells. Can you tell me the markers? हम बी सेल मार्कर्स देख रहे हैं. सो व्हाट वाज द पैन बी सेल मार्कर्स बच्चों? व्हाट वाज द पैन बी सेल मार्कर? सो व्हाट इज द पैन बी सेल मार्कर? फटाफट बताओ, चलो खत्म करते हैं क्लास. पैन बी सेल मार्कर्स बताओ यार फटाफट. Yes, 19. So please make a note of it. Yes, CD 90 and 20, because we are reading the B cell lymphomas. CD 90 and 20 will be positive. With that, obviously, BCL is increasing. So BCL2 will be positive here also. Please make a note of that too. Right? So can you see over here some cells that is shown? चलो ये वाला डायग्राम देखते हैं. It is looking like a buttock, right? So it is a cleaved cell or buttock cell, right? So it is looking like a heart that you make usually. Says to be heart. So it is looking like a buttock cells or cleaved cells. है ना. So this is a buttock cell, proper buttock cell, right? So ऐसा कुछ cleaved cell अगर दिखे, so please remember, so these are none other than the follicular lymphoma. This is leading to towards the follicular lymphoma. Let's move on to the DLBCL. DLBCL obviously diffuse है, तो world में भी diffusely present है. So non-Hodgkin में, which is common worldwide, this is going to be the DLBCL. Okay, so world में भी diffuse है, please remember like that, है ना, diffusely present worldwide. Okay, so that is going to be DLBCL. There are three types: idiopathic, BCL6 related, and follicular lymphoma, which is transformed into the DLBCL. Now, there are two transformation that we learn which can get converted into DLBCL. पहला हमने पढ़ा था रिक्टर्स ट्रांसफॉर्मेशन. अगेन आई एम मेकिंग अ नोट ऑफ इट, इंपॉर्टेंट है, क्वेश्चन आता है इस पे. सो CLL कैन गेट कन्वर्टेड इनटू DLBCL, रिक्टर्स ट्रांसफॉर्मेशन. और फॉलिकुलर लिम्फोमा जो अभी हमने पढ़ा, दैट कैन गेट कन्वर्टेड इनटू द DLBCL. That is a type of the DLBCL. Thankfully they haven't give any name for it. And यहाँ पे BCL6 positive होता है, diffuse 6, follicular में BCL2 is going to be positive, है ना. So please don't get confused between 6 and this thing, the BCL2, है ना. Follicular lymphoma, if you form the short form FL, है ना. Follicular lymphoma ज़्यादा बड़ा नाम नहीं है. Follicular lymphoma only 2 this thing alphabets are there, and DLBCL 5 alphabets, so add 1, है ना, 6 कर दो उसको, ठीक है. So BCL2 is going to be present in the follicular. Don't make a mistake of it because both are going to be in the options. Don't make a mistake. Follicular में BCL2 positive होता है and BCL6 is positive in the DLBCL. Okay, diffuse थोड़ा सा बड़ा नंबर होगा. And then comes the 8 over here, that is again EBV, Epstein-Barr virus से Hodgkin lymphoma भी था, and this is also associated infection के बाद transformation भी हो सकता है इसका. And HHV, human herpes virus 8, the relation is there definitely. Diffuse है, means it is involving much more things. And I told you somewhere, we also read that this is more aggressive to में यहाँ पे भी लिखा है, somewhere also else also we have read that, I guess CLL में देखा था हमने. So it is aggressive, so it is going to have worst prognosis. And यहाँ पे आपको क्या मिलेंगे, it's so difficult to say, right? क्या कि हमें diffuse large B cell देखेंगे. So if you see diffuse large B cell, which lymphoma you are going to mark? Obviously DLBCL. Okay, चलो. So this is CD19 and 20 positive and BCL6 positive. Usually they ask the question on this BCL6 positive. Again B cell lymphoma ही हम पढ़ रहे हैं. This is sub type of B cell, so 19-20 positive, है ना. चलो, can you guess what is this? Can you guess? ऐसा कुछ picture, इसमें से कोई भी picture आए, can you guess? This is a typical diagram coming in the exam, in all type of exam. What is the diagnosis of this disease? चलो जी बताओ, what is the diagnosis of the disease? Okay, so it takes time, I guess, from the net that to guess what is it. Right, I'm getting the, yes, so it is Burkitt's lymphoma, right? अगर बोला है अफ्रीकन चाइल्ड, है ना, अफ्रीकन चाइल्ड विद द जॉ स्वेलिंग, इतनी बार पूछा गया है एग्जाम में, many और times this is asked. If such diagram or such pic is seen, it cannot be any other than the Burkitt's lymphoma. Please make sure that you cannot miss this. Okay, Burkitt's lymphoma, again most aggressive lymphoma, and there are of 3 type. Endemic मतलब अफ्रीका में most common आता है, non-endemic and associated with HIV. Also 3 types है, कोई नहीं पूछेगा. Especially they are going to give the African child with a jaw swelling. Usually they have given this. Association Epstein-Barr virus से 100% होता है. So they are going to give you either the case scenario. Suppose they haven't give you the pic of any child. So they have given the scenario that a child got infected with the EBV and he's having jaw swelling. Africa mein. Definitely it is again Burkitt's lymphoma. Again, this is having somewhat association with the EBV, not 100%, not all the time. Nobody is going to ask you that, and usually this occurs in the adults, and A for adults, A for abdominal mass is also there, which is non-endemic type. Usually it is not asked in the FMG exam. Please remember, अफ्रीकन चाइल्ड में अगर मिला आपको EBV के बाद में कोई भी जॉ स्वेलिंग, definitely it is going to be Burkitt's lymphoma, right? Can you tell me which gene is mutated over here? You must have learned about c-MYC, n-MYC, l-MYC, right? So you must have read about the MYC genes, which are oncogenes, tumorous genes, right? Oncogenes. इसमें से c-MYC, l-MYC, n-MYC कौन सा होता है बच्चों? Which is affected over here? I don't know. I have given that in the this thing notes or not, you know. So definitely it is going to be the 814, T814, which is going to be most common. 8 will be involved most commonly, and this is going to involve the oncogene, which is c-MYC. Okay, B के बाद C आता है, so please remember it is not going to be l-MYC or n-MYC. B के बाद C आता है, so please remember Burkitt's में the c-MYC will be involved. Okay, c-MYC. All of you are right. Devendra, Patel, Dr. Fitch, Gerald, Tanya, Faraz, yes, all of you are right. So c-MYC, right? Then there are other mutation 28, 822, right? 821 नहीं होगा, बाकी सब छोड़ के 821 छोड़ के 814, 28 and 822 अगर कोई लिखा हुआ है, so can be Burkitt's. Okay. Starry sky appearance, somebody just now told that starry sky appearance will be there. What is starry sky? Tumorous cells will be there, but to eat those tumorous cells, the macrophages will be there. So those macrophages will be having star-like appearance, and in the background everything will be blue like a sky, you know? So which are going to denote the tumorous cells. That is starry sky. Again, this is a B cell. So CD 19 and 20, it is going to be positive. Something new came, that is KI67, that is also positive, right? So don't miss that. Okay, so that is the starry sky appearance. Can you see over here, appreciate the stars? These are stars, very weird stars, but yes, they are present in our blood also, not in our blood, African child's blood, right? So that is macrophages. You know? And can you appreciate the RBCs somewhere? No, because we are talking about lymphoma, not about the leukemia, right? So the whole thing will be blue. You won't be seeing any RBCs in the background, nothing, right? So it is very, very easy that it is lymphoma for sure. Everything is blue, blue, blue. That means that giving you the lymphocyte ka HPE, right? Histopathology of lymphocytes. And there is a gap in between, that is nothing but the macrophages which are trying to eat or trying to control the lymphoma, right? So the macrophages look like a stars, and in the background there's a blue tumorous cells that are the sky. Okay, coming to the mantle cell lymphoma. Mantle cell lymphoma coming from the mantle zone, है ना? So how to remember? I told you 14 will be coming many places in the B cell. In the follicular, I told you 14 is to 18, है ना? I told you how we used to remember FO for 14 and then 18, right? 14 is to 18. Transformation. Over here, the last two digits are mantle, है ना? If you reverse them, it will become LA, right? So EL is 11. So 11 and 14. 14 will be there, 11 and 14. That is mantle cell lymphoma. With that, we do have cyclin D1 expression also. Is a thing that it increases the proliferation. Cyclin D1 is actually a booster for the stem cells of the lymph node. So it is actually, if it is increased, so lymph nodes are going to proliferate abnormally high level. At abnormally high level, definitely it will lead to lymphoma, specifically the mantle zone lymphoma. Markers क्या होंगे बच्चों इसके? Please make a note. Though it is the B cell lymphoma, big वाले आने चाहिए थे positive, but over here the CD5 is positive and CD23 is negative. So please remember that yes, it is B cell lymphoma, but still CD5 is positive over here, है ना? So it is mantle, कुछ भी हो रहा है इसमें, right? CD5 is positive and there is one more gene which is positive. Recently means 5-6 years back this has come. SLOX11 positive is going to be there. Okay, chalo. Marginal zone lymphoma. What about the marginal zone lymphoma? Yes, over here the malt cells. What are malt cells? Mucosa associated lymphoid tissue, है ना? Mucosa associated lymphoid tissues are there. So that is going to cause the tumors. So that will be called as myeltoma. Okay. म्यूकोसा एसोसिएटेड लिम्फोइड टिश्यू, मोस्ट कॉमन साइट क्या है बच्चों? माल्ट का होता है आइलियम, प्लीज रिमेंबर दैट, बट माल्टोमा इज मोस्ट कॉमन इन द स्टमक, है ना. माल्ट टिश्यू मिलता है आइलियम में, बट इट वोंट ग्रो दैट लार्ज, है ना, प्रोलिफरेट इतना नहीं करता है, बट स्टमक में डेफिनेटली इट इज गोइंग टू proliferate. Reason we'll see. And there is two types, maltoma types and extranodal, that is orbit, है ना. So please remember, what is the etiology of maltoma? Very, very interesting question. What is the etiology? Repeated stimulation of lymphoid tissue, है ना. And yes, Faraz absolutely right that it is the only lymphoma. Yes, it is a tumor, but we can treat it with antibiotics. Why? Because the bacteria is involved in this, right? So that is H. pylori is involved in this, and RA is going to be there, and Sjogren syndrome, Hashimoto's, what are they? Chronic inflammation is occurring in all these conditions. If you note down this, Sjogren syndrome mein Hashimoto's thyroiditis, itis is there, inflammation is there. RA, it's full of arthritis, rheumatoid arthritis. Arthritis, itis is inflammations, joggers में भी आपका inflammation is there, and H. pylori तो है ही obviously, and that's why H. pylori can live in the stomach. This is the only bacteria can live in such a high acidic pH. So definitely it will cause the stomach maltoma, and that's why the most common site for the maltoma is maltoma, not the malt tissue. Maltoma, most common site is going to be stomach, and this is the only we can say this is the only tumor which we can treat with the antibiotic, but that is only for the early stages. Later on stages, obviously it is cancer, we have to go for the chemotherapy. Chemotherapy is common in lot many things, so they won't be asking you about the chemotherapy per se. So please remember, what is important to know right now is antibiotic से एक ही tumor treat होता है, that is maltoma, which is because of H. pylori. Please take care of your stomach, right? So Helicobacter pylori, antibiotic याद रखना. कौन सी एंटीबायोटिक देते हैं? कैन यू टेल मी व्हाट इज द गोल्ड स्टैंडर्ड टू ट्रीट एच पाइलोरीज? ट्रिपल थेरेपी. यस, गुड. ट्रिपल थेरेपी में भी कौन सी सबसे ज्यादा इंपॉर्टेंट है बच्चों? विच irreversibly, that means reversible नहीं हो सकता, irreversibly block the H plus pump, that is proton pump. Okay, last one in the B cell, that is hairy cell leukemia. Easy है, इसमें कुछ नहीं. hairs किस में ज्यादा होते हैं? boys में ज्यादा होते हैं ना, not on the head, other places, right? So in the boys the hairs are common, right, on the face, on the hands, on the legs, है ना. So cross sectional area total देखे तो hands, legs and everywhere the boys are having more hair. So please remember, it is more common in the boys, है ना. Obviously boys से है, and it is a B cell lymphoma and BRAF mutation. So please remember BBB everywhere in the hairy cell leukemia. So boys में common है, B cell है, we know that, saw in the first slide itself, and BRAF mutation is going to be there. The cells, they look like a hair, they look like as if they are having hair like projection, right, in the phase contrast microscopy, and that's why they are called as the hairy cell leukemia in the blood, right? So pancytopenia, ल्यूकीमिया है तो बाकी सारे सेल्स कम होंगे. सो एल्डरली में दिखेगा पैनसाइटोपिनिया, एंड ल्यूकीमिक रेटिकुलो एंडोथेलियोसिस इज गोइंग टू बी there, right? So it is actually a lymphoma, but it comes in the blood later on, and once it comes in the blood, usually it is diagnosed at that time itself, and that's why it first of all, when they diagnosed it via peripheral smear, they thought it is a leukemia, but later on they found out that it was actually a lymphoma. तब तक नाम पड़ चुका था उसको, hairy cell leukemia, है ना. So उसमें हम they haven't changed the name yet, so we are learning that into the lymphoma, but please remember, don't go by the name. It is not per se a leukemia, but it will convert into leukemia. So you can see the RBCs over here. Lymphoma mein you won't be seeing in the backgrounds any RBCs, okay, usually, but this is a special case over here. It comes into the blood, and can you see, we see as if it is having projections, है ना, hair like projection, halo दिख रहा है, कुछ आ रहा है उससे बाहर, right? So like that, है ना? So this is known as hairy cell leukemia. If you see something like this which is coming out of the cell but the borders are intact, borders are not like smudge cells and all, है ना? Smudge cell में तो the whole cellularity, the whole plasma membrane is ruptured, so everywhere it is going to go and you won't be able to appreciate the nucleus in that. But over here we are appreciating the nucleus, we are able to appreciate the borders also, but there are some projection, hair like projections, right? So if it is there, bone marrow में what we are going to get, aspiration में bone marrow में dry tap मिलेगा हमें. Again, if there is a dry tap, then teardrop cells can be seen. But यहाँ पे important क्या है? Honeycomb appearance and fried egg appearance. Yes, omeprazole, right? So PPIs are the gold standard, which I asked beforehand. So please remember, irreversibly ये 24 hours के लिए block कर देता है. 24 hours के बाद नए proton pumps बनते हैं PPI में. This question was asked in the exam also, but this is not my topic per se, है ना? चलो, fried egg appearance, इसमें CD11 is positive, CD25, CD103 is going to be positive. They are going to give you something like this, annexin A1, है ना? Everything is special in this. So CD के साथ साथ annexin A1, है ना? This is a topping in the exclusion, है ना? So all these exclusion criteria are there. And please remember, usually in the spleen, we talk in terms of white pulp and red pulp, right? This is the only thing which is going to involve the red pulp. Chalo, we'll see that later. Stain mein, you have to remember hair which are trapped in the cell. It looks like it is trapped in the hair, right? Cells are trapped in the hair. So you can remember that hairy cell leukemia mein, it is going to be trap positive, that is tartrate resistant acid phosphatase is going to be positive. Okay, so that is going to be there. Lymphoma में हमने पढ़ा था acid phosphatase. I told you acid phosphatase is going to be positive, and again in the lymphomas में we are seeing that the acid phosphatase is positive, which is trap again, right? And involves the red pulp which is there. Even if you remember, even if you forgot, it's okay. Okay, but please remember this trap over here, right? And the honeycomb and fried egg, I'll show you in the next slide most probably, and cladribine. Cladribine is going to be the treatment. Okay, so can you see, it looks like, yes, many empty combs are there. So this is the honeycomb appearance and this is the fried egg appearance, है ना? So this cell over here, not this one, this is the honeycomb, है ना? So over here, which I'm marking as a cross, that is the honeycomb appearance, that in between the combs are there and the honeys are there, right? So this cell over here, it looks like a, over here it is marked, this is looking like a fried egg. बीच में ऐसे lacunar cell की तरह ही, but you can not that big, right? So this is going to be the lymphocyte, and in between somewhere they are going to mark that, right? So this is going to look something like this, which is fried egg appearance. आते हैं T cell lymphoma में. Just give me 5-10 minutes more, right? 10 slides के आसपास कुछ बचा है हमारा. I told you T cell lymphoma, anything related to skin, है ना? It is collection of the T cell underneath the skin, है ना? I'll show you first of all this diagram. See over here, suppose these are the keratinocyte. What you can see over here, these are the swellings which are going to see beneath the skin, है ना? Skin lesion लेके आएगा basically. And if they are collected together under the skin, that is known as Portier's macro abscesses. Okay. And they're going to have special type of the, if it involves in the blood and if you take the smear, obviously ये skin का smear तो लग नहीं रहा है ना, smear जब भी देंगे तो we are going to take the smear from the blood and not from the skin. That is very obvious, है ना? So blood का smear अगर लेंगे, that means it is involving the blood. You're going to see abnormal nucleus again over here. Then that is going to be, they are going to give you the skin का condition, something like that. So this is the cerebriform, है ना? हमारे जो cerebrum होता है, that is also have sulci and gyri, है ना? Post central gyrus, pre central gyrus, many are calcarine fissure के आगे पीछे सब gyruses and the sulci are there. So that's why we see, it seems like cerebriform nucleus, right? And CD4 T cells are going to be positive if we note them now, right? So this is known as Sézary syndrome. So please make a note, if it involves blood, सेजरी सिंड्रोम। ऐसा कुछ डायग्राम दिया हुआ है, स्किन का कुछ एब्सेस बताया हुआ है, ग्रोथ बताई हुई है अंडर द स्किन, एंड देन दे हैव गिवन दिस डायग्राम एंड समवेयर इट इज मेंशन सेरेब्रिफॉर्म न्यूक्लियाई, और दे हैव गिवन दिस टाइप ऑफ डायग्राम। स्किन जहां पे भी आएगा, इट कैन नॉट बी एनी अदर देन द mycosis fungoides, okay? Sézary syndrome and Portreous microabscess, रेड में जो किया हुआ है, that is important. Can you identify this cell? क्या है ये? ALCL, that is the anaplastic large cell lymphoma. ALCL is there. What is this called as? Yes, please. Hanji, answer. So yeah, it is late already, so it is, I hope you will give the answer of this, right? With that, the hope, I'll go ahead. The ALK gene, there is a gene which is known as ALK gene. Anaplastic mein ALK gene is going to be positive, and it looks like there is one cytoplasm and two rings of cytoplasm, hai na? Donut cell, right? You guys are right. So hallmark cells or donut cells are going to be positive. It looks like this is the hallmark cell, है ना? It looks like two cells are coming together, hallmark cell and donut cells are going to be positive, and CD30 is going to be positive over here, right? So see over here, CD30 is positive. I hope you made the note of it. Nothing special in this. So what is this? This is the hallmark cell. Very indented type of nucleus will be seen. So see, like this. This is known as hallmark shape, horseshoe shape, indented cell, whatever you call and whatever you remember as. H for hallmark, H for horseshoe shape. अगर horseshoe shape बड़ा सा कोई cell दिया हुआ है and horseshoe shape nucleus is there, H for hallmark, H for horseshoe shape nucleus. So ऐसा कुछ nucleus दिख रहा है, तो that is going to be your ALCL and donut cells. So you can identify very well, right? फाइन. सो लिम्फोमा में कुछ कॉमन फीचर्स आएंगे: फटीग, वीकनेस, वेट लॉस, नाइट स्वेट, माइल्जिया, पेल एब्स्टिन फीवर विच इज गोइंग टू बी साइक्लिक फीवर. टिपिकल आपको पैटर्न दिया जाएगा. फ्यू डेज ऑफ अ वीक some person is having fever, but after that he's not having. Again next week he's having fever, then he's not having. So it is a cyclical pattern which is repeating again and again. And lymphoma का कुछ history दिया होगा आपको. Any hint is going to be there. This fever is known as Pell-Epstein fever. Worsen with alcohol. Alcohol is anyhow, it is bad, right? Real classification of lymphoma, as if we are doing everything unreal, है ना? So please remember, thankfully it doesn't have any weird name. So lymphoma के लिए we do have real classification and there is a staging. Nobody is going to ask you this staging. Once the name was asked, that is Ann Arbor staging. Please remember the name itself, right? So moving on to the treatment, everyone knows. फार्मा की कोई भी टीचर की क्लास लगाई होगी, यू मस्ट हैव कम अक्रॉस समथिंग नोन एज आर्च ऑफ, है ना? आर्च ऑफ ट्रीटमेंट दैट इज गोइंग टू बी फॉर द लिम्फोमा. क्या होता है? रितुक्सिमाब, cyclophosphamide, hydroxydonorubicin, again oncovin is there, vincristine that is there, and prednisolone, है ना? So Cristin pal में से at least Cristin and prednisolone is there, right? चलो, adriamycin is also the hydroxydonorubicin, instead of that it is there, okay? Langerhans cell histiocytosis, short topic बच्चे हैं, again 8:30 पे खत्म कर देंगे, है ना? It is also known as histiocytosis X. Please make a note. Either they are going to give you in the option Langerhans cell histiocytosis or histiocytosis X. Clinical features, कुछ खास clinical features नहीं आएंगे, right? But skin rash, bone pain due to bone fractures and dislocation, it is going to be there. 4 types होते हैं इसके, right? What are the 4 types? Please make a note. This is very very important. Why? Because whatever I saw in the FMG questions, they have given this eosinophilic granuloma का history. अगर ऐसा कुछ दिया हुआ है, then bone fracture and ऐसा कुछ दिया हुआ है in the children, then definitely it goes or it points out towards the histiocytosis X. Please remember that, right? And the Hand-Schiller-Christian disease, ये children में दिखता है, 3 to 10 years. Pulmonary histiocytosis associated with smoking, है ना? What do you expect? Then and lateral severe disease infants में हुआ तो less than 2 years. If you want to remember the name, remember it. other than that, if you want to just overall see the slide, what you can see, any specific symptom? No, bone fracture, and you will start thinking in the ortho phase. But as soon as you see the options of lymphomas, Langerhans cell, histiocytosis, please remember, अगर eosinophilic granuloma कहीं पे दिया हुआ है, then it cannot be any other, and especially they are going to give you the case scenario of children, then it can be only and only the little bachas, that is Langerhans cell histiocytosis, है ना? Little children, please remember, little children with the eosinophilic granules, right? So that are going to be the Langerhans cell histiocytosis, and luckily it is benign, है ना? It is benign, and these two are going to be pre-malignant. Hand-Schiller-Christian disease and literal severe disease, they are going to be, yes, they are going to be pre-malignant. Now, can you see this indented type of cell, right? This indented type of cell is going to be there if that is there. If you divide it into two, है ना, यहाँ पे भी आपको दिख रहा है, though it is not mentioned, but if you see some indented type of cell that it is divided into two, it is a specific cell which can be seen in the Langerhans histiocytosis. So that is all for today's class. I hope you like the class, है ना? कैसी रही, क्या हुआ, कुछ improve करना है तो बता देना, right? And tomorrow we are going to start with this nice red looking cells, that is the red blood cell. That is all for this class today, है ना? See you tomorrow at the same time. Please revise करना 15 to 20 minutes. See you same time 5 p.m. tomorrow. Okay, bye guys.